Gynae Society to save mothers dying from PPH and placenta accreta spectrum. So we have 2 days full of academics and live workshop, video sessions, hands-on training, free papers, e-posters, quiz, grand inauguration, a cultural evening, and gala dinner. So welcome all delegates who have registered for this conference, and a special welcome to all of you who are here sparing your precious morning time. So we begin today's program with Ganesh Vandana.
वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
With divine blessings, we will begin today's scientific program. And in the beginning, I request Dr. Meena Samant, who has been working so hard for last 4 months, along with our very hardworking, dynamic organizing secretary, Dr. Amita Sinha. So Dr. Meena Samant, please welcome the guests who are here.
Good morning. Good morning, Namaskar. A hearty welcome to one and all present here. We have our guest faculty here, Dr. Patel, we have Dr. Deepak Desai here, Dr. Nalini Mishra, and so many of us seniors, including our past president, Dr. Modi, and so many other senior delegates. A hearty welcome to all of you. With the blessing of divine, let's begin today's bonanza. We have, like Dr. Ranjana mentioned, whole lot of activities planned here. I think you are going to enjoy it. We have come to learn here, and we go back more learned today from here. So welcome once and all to you. Thank you.
So very soon, we are going to start our live workshop. Spinal is being given in the NMCH OT. Dr. Vinita Singh, Chairperson Workshop Committee, along with her committee members, Dr. Supriya and Dr. Veena, are there along with their team working very hard for success of this workshop. And myself, our organizing secretary, Dr. Amita Sinha, Dr. Charu, and Dr. Mini will be here with you. Are you ready, Veena? Are you ready with the case, Veena?
Yeah. Hello?
Okay.
Hello.
So, Dr.
Good
Veena.
morning to all the respected faculties, my colleague and junior. It's my immense pleasure to start the auspicious occasion of PPH Conclave 2024 live workshop and video session. I heartily welcome everybody. Today we have gathered here for an educational and informative session. I start this program with blessing of God and enthusiasm of all the dignitaries and participants. Thank you. Now, case will start very soon. Dr. Deepak sir.
Very good morning to all of you. Now we are all set to start a live workshop. And the first case will be shown by Dr. Mahesh Gupta, a very renowned personality, who is a legend personality in the case treating PPH. So let us see how he shows us how to do the cesarean section and devascularization if there is any PPH. So I welcome one and all who is sitting in the hall in Moria Hotel. So let us wait for only 2 minutes and we will start. Now over to Dr. Mahesh Gupta, sir.
Yeah, good morning to all. And it's my privilege and proud pleasure to be here in Patna. And this Foxy PPH conference is organized by Patna Society. And here in the operation theater, we are starting our first case at Dr. Madam Vinita Singh and everyone present here. So first case, the resident will tell you the history and then how we can proceed with the evidence-based cesarean section technique that I'll demonstrate. Thank you so much.
Thank you. So everybody stay tuned. The spinal is being given. So straight away in 5 minutes, 2 minutes actually, we'll go start the case. Sir is going to start the case.
Good morning, everyone. Now we are about to start our first case. The first case will be done by Dr. Mahesh Gupta, who is our National Advisor, PPH Committee. And Sir will show us evidence-based cesarean section technique with stepwise vascular ligation. And Sir will be assisted by Dr. Pratibha Prakash ma'am, who is our Assistant Professor from NMCH, and along with our postgraduate student, Dr. Lovely and Dr. Shivani. Our anesthetist is Dr. Ravi Kumar, and our pediatrician is Dr. Tanmay Patra. The sister on table is Sister Sudha. So our first case is a primary gravida who is 21-year-old from Patna. She is 40 weeks plus 2 days of gestation by her last menstrual period. She has been given 3 doses of Serviprim gel, and our indication for today's cesarean section is failed induction. So now Sir is going to start the case. Thank you.
Done by Dr. Mahesh Gupta, sir. May we have Dr. Mahesh Gupta, sir, CV, please? And sir will be operating, and the topic is evidence-based cesarean section technique with stepwise vascular ligation. And then we have a video session by Dr. Deepak Desai, sir, Management of Traumatic PPH. And then, yes. So may I request Dr. Charu Modi to kindly introduce Dr. Mahesh Gupta, sir. As all of you know, Foxy PPH Conclave is being guided by our Foxy President, Dr. Jaideep Tank, Secretary General Dr. Madhuri Patel, our National Convener Dr. Mahesh Gupta, sir, National Advisor Dr. Bhaskar Pal, sir, and hosted by Patna Obs and Gynae Society. I'm sorry, Dr. Mahesh Gupta, sir, is National Advisor, and Dr. Bhaskar Pal, sir, is National Convener. And Dr. Alka Pandey, ma'am, and Dr. Abharani Sinha, ma'am, are co-conveners of this Foxy PPH conclave. So, Dr. Charu, please introduce Dr. Mahesh Gupta, sir.
Thank you, Ranjana ma'am. Again, a very good morning to all of you, and it's a pleasure to introduce such a renowned faculty, Dr. Mahesh Gupta sir, as has been told by Dr. Ranjana Sinha. Just to introduce him formally, Dr. Mahesh Gupta is MD and has received 2 medals in 1983 Gujarat University for Surgery and Medicine subject. And he has, as we can see, he has many awards to his credit. He has received Times of India Health Icon Award, Ahmedabad in 2018, and has developed patented and published techniques to control PPH, which he is going to demonstrate us live from NMCH OT, the different techniques of devascularization in cases of atonic PPH or any torrential bleed from uterus. He's having American patent of suture materials used for cesarean section and PPH, which he'll be going to demonstrate to us very shortly. And he's the editorial board member in World Journal of Anemia, and he was also the past president of Ahmedabad Obstetric and Gynecological Society. He is ex-honorary convener of Gujarat State Gynecological Association, and as we can see, he's invited faculties in many places pan-India, and we are fortunate to have him here today, which will be seeing him live. Thank you so much.
Thank you. I'm really, my two co-chairpersons, Dr. Supriya Jaswal and Dr. Veena, they have worked very hard along with me. And I have tried my best to keep, all the procedures which is related to save the life because of PPH. So here I would like to welcome our principal because she has, given us opportunity to do this workshop at NMCH premises. So she wants to say a few words. Dr. Usha Kumari, she is principal of our NMCH.
Hello, good morning to all of you. It's a very proud privilege for all of us that the workshop is going to be held at Nalanda Medical College. So we are very happy, and our team did a very hard work for today workshop. So I wish for a grand success of this workshop, and also I must congratulate the guest, Dr. Mahesh Gupta, and their team for coming here and taking pain uh, uh, here. So thank you very much for all of this. So please enjoy the workshop. Thank you very much.
So the patient in 1 minute, sir will start the procedure. So I think in this, he will be showing evidence-based cesarean section because there is little changes in how to do cesarean sections, and he will tell us what he has done before and during procedure and after, cesarean sections to reduce the incidence of PPH. And also, he will be showing us stepwise devascularization of uterine artery and ovarian artery. So let us see how he do the procedure and how he do the devascularizations.
Patna.
Am I audible there?
Yes, yes. And visibility is
so-
also good.
So we are starting a new case. As far as the skin incision is concerned, traditionally this is a phalangeal incision. And if we go for anterior superior iliac spine, both the side, and we can make an incision here, that is a Joel Cohen incision. So all the data suggests that Joel Cohen incision is better than the phalangeal incision as far as the bleeding is concerned, as far as the post-operative pain management is concerned, and as far as speed is concerned. But the only drawback is a cosmesis, because this incision will come almost here. So as far as the cosmesis of the concern for the female, it looks little high. So now everybody had modified a Joel Cohen incision. So we'll go little below, not exact on the Joel Cohen, but little below. Here the Misgav-Ladakh is a technique, it's not an incision. When the various steps combined, that is called a Misgav-Ladakh technique. But here the incision is a Joel Cohen. So now what we'll do, we'll go for a modified Joel Cohen incision, and generally I'll put a Alice's forceps, hold it, to mark my incision, because the incision and scar is a signature of the surgeon. So I am marking my incision by putting two Alice's forceps on the either side, and I will ask the assistant to hold it, and with one hand she will place like this, okay, knife.
PH during a case of cesarean section. So as it was really wonderful. And so we are moving ahead. We are almost 15 minutes late, so we'll go fast. And now we will be having our video session. Can we switch off the OT? Okay, thank you. So the next is the video session by Dr. Deepak Desai, sir. And for that, I am really honored and privileged to invite our past presidents of Patna Ops and Gynae Society, Madam Manju Geeta Mishra. Madam, please come over the dais and take a seat. Madam Pramila Modi, Madam, please come. Madam Anita Singh, Madam, please. Madam Abha Rani Sinha, all have blessed us for so many years. All of us who are standing here who have the courage to organize this PPH conclave, a national level conference under the leadership of Dr. Meena Samant. We are really guided by them, and it is their legacy that Patna Obs and Gynae Society members are able to do anything. So with that, we begin our video session with Dr. Deepak Desai. Can we have the CV of Dr. Deepak Desai, sir? This workshop has been very meticulously planned under the guidance of Chairperson Workshop Committee, Dr. Vinita Singh, along with her committee members, Dr. Supriya Jaiswal and Dr. Veena. Yes.
First of all, I'd like to thank the organizing committee for inviting us to chair this very important video session. And as the presenter, we have a very accomplished person, Dr. Deepak Desai, who is consultant obstetrician and gynecologist at Virar Maternity Nursing Home, Virar. I think we have witnessed him before also. He had come for the ICCOB in 2017. He's MD from Grant Medical.
Due to PPH is reduced significantly, near-death incidences do occur. In India, it is the #1 killer of our mothers. So previously our definition was, there was a fault in the definition. 500 cc at the normal delivery and 1000 cc at the cesarean section. Why wait till 500 cc? We don't wait. So now new definition is there any post-delivery bleeding which has a potential to cause hemodynamic compromise should be considered at PPH. So एक बूंद भी अब जाना नहीं चाहिए क्योंकि अपने मदर्स सब एनीमिक रहते हैं ज़्यादा करके तो एक बूंद also counts there. So early detection is what is important. See, previously when these mobiles were not there, we had this 4 alarm clocks. They were, every 15 minutes their alarm clocks used to go. Relatives are told कि patient sister को लेके आओ. वो patient को every 15 minutes जो देखना होता है वो होता नहीं था. That was what we realized. 2-3 cases I realized that we are detecting PPH at the grade 3 and grade 4 by the time patient is already morbid. So अपने को early detection होना चाहिए. तो कौन से भी हालत में करो. जैसे कि we had these 4 alarm clocks and nowadays we have these monitors. And with monitors we we have a group of, our hospital has a group of WhatsApp group. So where everybody is involved. So every 15 minutes the photograph of this monitor is sent and sister is told that see to it that you see whether there is a bleeding or not or there is a, uterus is, the height of the uterus is increasing. So with this and little amount of fresh bleed, immediately the doctor has to be seen the patient. So that's why, see, we started this because we have got good surgical methods, we have got good uterotonics and all, but detection is late, that's why the main problem. So when we started doing the last almost 20 years now, and hardly we have given a blood transfusion. Hardly, I'm telling you, hardly we have given a blood transfusion in a PPH cases. We do have PPHs, but they are detected earlier and managed fast. So let's analyze this PPH. See, most of the cases are like primary atonic or traumatic or bleeding from the placental site. So primary atonic, we are using prophylactic techniques like uterotonics and third stage management and all. Traumatic PPH, I'll go in further details in traumatic later, and bleeding from the placental site. All these three, if not properly and timely treated, then they go into a secondary atonia. What is the secondary atonia? Because the patient goes into hypovolemia, hypotension, and hypoxia, mainly because once the patient goes into hypotension, the nature tries to save our brain and all, so the splanchnic blood supply and the uterus blood supply stops, reduces. So the oxygen supply is gone. So there is no ATP generation. So if ATP is not generated, how the energy is going to be there to contract? And that's why our utotonics don't work in a secondary atonia. So we don't want our patients to go into a secondary atonia. That is what is our aim should be. And then there should not be any problem. So traumatic PPH. In a vaginal delivery, we'll be having either a bleeding vagina, bleeding from the vagina wall, or bleeding from the cervix and bleeding from the lower part of lower segment. So most of the times what happens, see vaginal bleeding we know exactly दिखता है कि इधर से bleeding आ रहा है, लेकिन cervical bleeding is missed because most of the times what happens when the baby comes out there is a stretching and that causes the mucosa gets stressed and mucosa is a single layer columnar epithelium. Below that there are vessels, so tear हो जाता है. अपने देखते हैं कि suction evacuation करते समय अगर रिलीज नहीं करो सक्शन और खींचो तो वहां से ब्लीडिंग होना चालू हो जाता है. पाइल्स का ब्लीडिंग कैसा होता है? सेम. सो एंड इट अपीयर्स दैट इट इज कमिंग फ्रॉम द यूट्रस. माउथ से आता है, माउथ ऑफ वोम से आता है, तो अपने को लगता है सो यूट्रस कॉन्ट्रैक्टेड है तो भी वी कीप ऑन पुशिंग ऑन यूट्रोटॉनिक्स. सो वंस द यूट्रस इज वेल कॉन्ट्रैक्टेड, सी इट इज एंड द पेशेंट इज ब्लीडिंग, it is bleeding from the cervix and that is the mucosal tears. So these mucosal tears are missed. Most of the times what happens, traumatic PPH, cervical tear यानी अपने को सिखाया गया कि खोल के देखो अगर tear है कि नहीं. These apparent tears, they don't bleed much. Main is the cervical, the mucosal tears bleed. So the vaginal delivery में bleeding from the vagina can be easily tackled. Bleeding from the cervix and bleeding from the lower part of lower segments. Nowadays we have large babies. Because of that, instrumental deliveries have increased. And other thing is nowadays with this lateral mastoplasty, again the cervical trauma is more. So so that is the thing. And in cesarean section again, either you have a upper segment bleed or upper part of lower segment, lower part of lower segment, extension of lower LSCS and broad ligament hematoma. So इसमें कहाँ क्या करना है वो important है सबसे. So when you see that uterus is well contracted and patient is bleeding, consider it to be a traumatic bleed or small placental crease remaining. So you have to have a bundle approach. Uterus contract होने के लिए अपन already uterotonics दिया हुआ है. Evacuate the uterus and take sutures on the cervix. So conditions which might cause traumatic PPH in vaginal delivery is precipitate delivery, fetal macrosomia, scarred cervix, instrumental deliveries, induced and augmented labors, lateral metroplasty. All this has increased. ये सब बढ़ गया है, इसके लिए bleeding बढ़ गया है, इसके लिए PPH हो गया है ज़्यादा. तो उसके लिए क्या कर सकते हैं? I am going to focus more on a prophylaxis. We have a medical prophylaxis. We are using it outright. But surgical prophylaxis. So in all these cases where we suspect कि precipitate delivery हो गई है, macrosomia है, ऐसे कुछ भी रहा तो immediately you take lateral cervical stitches 3 o'clock 9 o'clock and the bleeding will stop. So ये करना बहुत ज़रूरी है. तो ये important steps हमने चालू किए तब से कुछ problem नहीं है. आते आते ही मैं एक lateral stitch लेके आया हूँ. So safely I could come. So traumatic PPH in LSCS, again same fetal macrosomia and deeply engaged head. When you get the head out, again the lower segment is stretched and you get bleeding. So apparently अपने को लगता है कि ऊपर से आ रहा है, uterus contracted है and bleeding, it is a traumatic bleeding. So to understand what to do, we have to see the blood supply of the. See, the uterine artery from anterior division comes like this. It divides into two, ascending uterine, the descending, and there are cervical branches from the uterine also, and there are vaginal arteries which are giving branches to cervix also. So when bleeding from the, so when in a cesarean section, if there is a bleeding from the upper part of lower segment, you can take a suture here that Dr. Mahesh Gupta showed us today. So lateral stitch here and the bleeding is stopped. If it is lower down, lower part of lower segment, here there is a niche. Because there, if you try to take a stitch, you are close to ureter. So in this lower part of lower segment, whenever there is a bleeding from lower part of lower segment, go and do intra-iliac. Traumatic PPH, as doctor said, intra-iliac works only in traumatic PPH, mainly is because of that. See, in a atonic PPH, you have to just reduce the blood supply to the uterus. So there you just take a lateral stitch here and it works. So in atonic PPH, internalic की ज़रूरत ही नहीं है. It is not going to work. And one important thing is in internaliac ligation, I'll come to that later also, but only internaliac artery ligation is not going to work. मैंने यहाँ बांध दिया, यहाँ का supply गया, लेकिन ovarian axis is there. So it has to be combined with a ascending uterine so that ovarian axis is gone and the internaliac. So we'll concentrate on cervical here. So cervix suture करने के लिए you used to use sponge holding forceps, but most of the times you have found that कभी suture लेते तो उसके eye से चला जाता है. तो इसीलिए you can modify this. This is a cervix holding forceps, very easy, and we have to have a good retractors. This is our retractor which we have modified from the Verjam's retractor. It's very easy to work in the cavities. So to eliminate morbidity and mortality of the postpartum hemorrhage, let us start using prophylactic measures, even surgical measures. Let us detect the hemorrhage, obstetric hemorrhage early, and let us analyze PPH and treat it properly, and we shall achieve the goals. So let's see the videos now. First, I'll show you cervical stitch. This we do it as a prophylaxis. So here in this case, you see that she is not bleeding much. She is not bleeding. But there is a tear, and this was a large baby which we have delivered. So I don't want the patient to go in the wards and then start bleeding. So lateral stitch le lene hai. So this is a simple stitch which you take, hold with, this was a old time technique. So where I am using a sponge holding forceps. It is better to have two assist sons and good retraction. So a sim speculum one and a good retractor on the upper part. So here you can see. So you can easily see the uterus. Uterus is mobile organ. थोड़ा सा ये करो या तो सिस्टर को ऊपर से जरा प्रेस करने को बोलो, सर्विक्स आराम से दिख देता है. So here we use polyglactin 910, 10 या 1 number, 40 mm needle. We take a double suture like this because see this acts as a, first suture acts as a stay, you pull down and take another suture. So you can take a larger bites so the bleeding can stop. So see, if you see the blood supply to the uterus and the cervix, the vessels, they are coming on the lateral sides and then go in an arcuate fashion. They go circular and then they go have a radial arteries. So when you take a lateral stitch, you obliterate this. So but there is a excessive bleeding and tears. This also is not going to work. So there you will require a vertical stitch because if you see the blood supply, ऐसे आते हैं फिर बाद में ऐसे जाते हैं. तो अगर vertical stitch लिए तो on uterus as well as on this works very well. So recently we have started taking sutures, which I'll see. This is, I am taking a double stitch now. Here with this, a suture can go through the eye of the forceps. So on the other side now. This is cranial end, caudal end. Simple stitch can be practiced on any patient also. So whenever there is a large baby, wherever there is a precipitate labor, when there is a scar on the uterus, your cervix, you take this stitch. And it has worked the wonder. Simple. Only thing, good exposure is required. So you have a good assistance. And I'll show another video now. This is lateral vertical stitch. It's too bright, I suppose. Is it visible too bright? It's too bright. So I'll another video I'll show. I think this is better. Oh, here again you can see this patient was bleeding. So we have so first take a lateral and then go vertical. So here we have taken a lateral stitch first. So go, like take a lateral stitch, go up, come from anterior to posterior, and then come down, and near the os, you go from back to anterior again. So here I am going from posterior surface of the cervix near the os. So it becomes like a 3 o'clock, 9 o'clock vertical lateral stitch first. That acts as you can stay also, pull down, then go as high as possible, almost up to the junction of the vagina and cervix, and there you go from anterior to posterior, then from posterior near the os, from posterior to anterior, and tight. So it blocks all the vessels, and this works very well when there is cervix is profusely bleeding. Pardon? See, 3 o'clock, 9 o'clock. Say now I'm taking a stitch at 9 o'clock. You go as a, just a lateral stitch lete वैसा 9 o'clock के लिए, and then you go up anteriorly as high as possible, then go vertically down posteriorly and come downwards near the os, go from posterior to anterior and tight. So it will be like ऐसा स्टिच लेके आगे जाके ऊपर से पीछे आके आगे. So it is actually same suture, same. Yeah, continuous. So this I'll explain it on cesarean also. Same thing we take it on the cesarean also. So here again, we are using the forceps. So ये sponge holding के bigger ये लगा दें. So here again, we'll take first lateral stitch. So either you can see if patient is not much bleeding, you can just take lateral stitches, 3 o'clock, 9 o'clock. If patient is profusely bleeding, you can take these stitches, then go up and come down, and so it will vertically notch like. So it works very well. Practicing is also very easy. So here again, ये अभी मैं ऊपर अभी यहाँ first I came to os, then अभी ऊपर गया, and then I'm like so this vertically it will. Posterior, posterior to anterior and tight out. Yeah, it works very well. As up as you go. See, say 3 o'clock I have taken, then I go up as high as possible and see to it that you are more close to the medial side. That is what you want.
Our aim is to reach the internal os.
Yeah, as high as possible.
No, you said not that we have to take out the stitch at the level of the os. So you mean internal os?
Yeah. So the other thing is that if doing this, again still the patient bleeds, then the patient is bleeding from the mucosa of the lower segment, lower part of lower segment. So in a vaginal delivery, maximum burnt is on the os. So the most of the times it bleeds from the periphery of the os. So there it works very well. But if suppose in a larger baby instrumental delivery, if it goes clear up, then the patient is bleeding from the lower part of lower segment, and if the patient is bleeding from the lower part of lower segment, uterus is well contracted, here you have to do only internal iliac artery ligation. Otherwise, this patient is going to bleed, and this patient is going to a secondary atonia, where you will have to do internal iliac plus a compression stitches or hysterectomy. That's the thing. So let's see how it works in a cesarean section. Cesarean section again, see Dr. Mahesh Gupta told us about the lateral stitches on the ascending uterine. But here again, if you see, the blood supply to the uterus is coming from the ovaries as well as the uterine, and going, these are vessels are going in arcuate fashion like this. So if you take a vertical stitch, this stitch has now been demonstrated this, in Bombay. I think Dr. Ashokananda from JJ Hospital, he has published one paper on this also. So here you go up, again a vertical stitch like that. So here now, see here the cesarean is already done. So here now we will be taking a lateral stitch now. See here, this was a case of placenta previa. So here, this is a lateral stitch we are taking. As in a, see we go more medially, tight medially over there. This is what Dr. Mahesh told us. This will reduce the blood supply to the uterus, that is definitely. But now I will be taking a stitch vertical so that the blood vessels going from lateral to medial side, they will get blocked. So here again, go as low as possible, retract the bladder, go low as possible, and then come out posteriorly between the uterosacrals. So here I have come posteriorly, and then you come close to the, from posterior to anterior, close to the round ligament. So here we are come. So this area, whole of this area will get obliterated. So we anchor this to the suture, the incision line, so that it will not slip. So now when I tight this will obliterate all the vessels which are going from lateral to medial side. The arcuate vessels which are going from the that ovarian axis se jo aate hai. Ovarian axis goes like this, utero-ovarian axis, and the vessels going like this, they are obliterated like this. So now here you can see it is totally, see, the uterus is getting, so here it is getting obliterated. This works very well. Recently, we have last 7-8 cases, we have started using this, and in cases of placenta previa and all, it works very well. So we did not require any intra-iliac ligation for that also. So here you can see. So same procedure like we do it on the cervix also, same. So the left side is already taken, here is already it is taken. So this is a simple, and especially for a placenta previa, grade 1, grade 2, it can be easily done. So here in this case, normally when you keep uterus for a longer time outside, exposed to the atmosphere, it desiccates, and desiccation is the worst trauma, and that's why. Yeah. Okay, this is last one. So desiccation is the worst trauma. Again in PPH, I'm telling you, when uterus remains outside for a longer time, it desiccates, and the uterus, the cells will not contract properly. So just hydrate the vessels just by giving saline wash. So we just put on saline whenever the uterus is out for a longer time, we just give like this. Oh, thank you very much. We'll see, internal iliac ligation has to be done. If all this fails, we have to do an internal iliac ligation. In my next lecture, I'll show you how to do internal iliac ligation and all. So, thank you. Yes, Bhaskar. इधर ही आना भास्कर इधर ही आना
that you showed, do you do that in atonic PPH also?
See, in atonic PPH, it can be done, but it is not necessary much because you just reduce the blood supply.
I think what you said is a very important point. When we were training for PPHs, we would do a uterine artery and then we'll go on to the internal iliac, which is a complete waste of time. Dr. Daftari taught us do the uterine artery and do the utero-ovarian artery anastomosis. That we did by a suture from just below the tube and coming out. In atonic PPH, that is what we do instead of the lateral.
Thank you very much. Well known for some songs. You see, गीत वो अपने ही मेडिकल गायनोकोलॉजिकल फील्ड को लेकर के वो कुछ गाने बनाए हैं और आपको बड़ा आश्चर्य लगेगा जान करके. अभी मैं शुरू में मैं बहुत पहले आ गई थी. We had a chat about it, about internal iliac. Is it? I'm right. So he has made a song for it, so that you don't remember don't forget the steps. Steps. Yeah. I know that, and we will be lucky today to hear a song. Please listen to me. Dr. Deepak will be presenting a song on Bihar. So we are Biharis. And he will be presenting a song on Bihar. 38 states you said, isn't it? No.
38 districts.
And is there some time? Ranjana, can you give some time that he presents Bihar? Bihar. Please go ahead, doctor.
Okay. पूर्व पश्चिम चंपारण और गोपालगंज सिवान सरन पटना भोजपुर बक्सर कैमूर रोहतस औरंगाबाद अरवल जहानाबाद गया नवादा जमुई शेखपुरा नालंदा बंका मुंगेर लखीसराय बेगूसराय सहरसा सीतामढ़ी शिवहर मधुबनी मुजफ्फरपुर वैशाली समस्तीपुर और दरभंगा सुंदर सुपौल मधेपुरा किशनगंज अररिया पूर्णिया कटिहार भागलपुर खगड़िया इन सुंदर बिहारी जिलों की राजधानी पटना मुखिया.
I have got the proud privilege of introducing Dr. Deepak Desai to Patna. Am I true? I have heard this song in New Mumbai, if I am right. In his conference, actually, I was introduced to him, and he made me listen to this song. And then I remembered Dr. Deepak Desai and called him for our AICOG first. And then my ICOB conference called him. And many times now Deepak has come to Patna. Thank you very much.
So, thank you, sir, for the wonderful presentation. And may I request our moderators to kindly hand over a memento to Dr. Deepak Desai, sir. Dr. Deepak Desai, sir, please come on stage. We have a memento for you. Dr. Meena Samant and Dr. Amita Sinha to join, please. And I have an announcement. There is a delegate lounge in exhibition area in Kesaria Hall. We have tea and coffee for you over there. And for our senior members and faculty, we have tea and coffee and snacks at Darbar Hall just besides the Kautilya Hall. So we are the NMCH OT is prepared for next case, which will be performed by none other than Padma Shri Professor Shanti Roy Madam and Dr. Alka Pandey Madam. And the case is, I think, internal iliac artery ligation. So may I request Dr. Bini Anand to kindly introduce Dr. Shanti Roy Madam.
Respected Padma Shri Shanti Rai Madam. Madam is Padma Shri, as I said, ex-professor and head Department of Obstetrics and Gynecology, Patna. She's ex-president Bihar Ops and Gynae Society, ex-member governing council of ICOG, and organizing chairperson of the 57th AICOG in 2014. She had actively done it and it was done beautifully, wonderfully, a very successful AICOG, and also a fellow guide, Narchi. So, madam will be starting, the case will soon be starting from NMCH. It will be relayed here and we will all be seeing how well, how intricately, how innovatively madam does everything, and she and Dr. Alka Pandey madam will be doing this case. So over to soon we will be seeing it. And in case you all want to have tea and coffee, as Dr. Ranjana has already said, you can take it and come back here and enjoy the next video session which is going to, the session which is going to be live from NMCH. Thank you so much.
In NMCH OT, the next case, as Dr. Mini has already announced, will be performed by Dr. Shanti Roy ma'am and Dr. Charu Modi to kindly read the CV of Dr. Alka Pandey madam, who is also co-convener of this Foxy PPH conclave. So Dr. Charu, please introduce Dr. Alka Pandey madam. Yes.
Thank you, Dr. Ranjana. May I have the CV of Dr. Alka Pandey, please? As we all know, Dr. Alka Pandey has been a very vibrant Vice President Foxy for this previous year. She is also the past president of our society, that is Patna Obstetric and Gynecological Society, and she is a great academician, a very dedicated and meticulous Foxian. She is the professor and HOD Department of Obs and Gynae, Lord Buddha Koshi Medical College, Saharsa. And as we all know, as I told you, she has been a very vibrant Vice President Foxy last year, and we have seen some very good work under her tenure. And she is very meticulous, very down to earth, and the one liner which suits her is words speak louder, work speaks louder than her. And she is also the operating faculty along with Dr. Shanti Roy for this next session. So over to you, madam.
Thank you, Charu. And now I think we should get the transmission from OT where they are ready with the case and someone will be reading out the case history. So Dr. Veena, history.
वीना मैम नहीं है मैडम हेलो दिखाओ इधर
Dr. Veena, are you ready with the case?
पोजीशन दिखाओ वीना
Can someone read the case history from the OT?
केस हिस्ट्री को तो बताएं
Who is going? Yes, please. What is the next case? As all of you know, the next case will be performed by Padma Shri Professor Shanti Roy ma'am and Dr. Alka Pandey ma'am will be with her. And now the case history.
Good morning,
Yes?
everyone. Second case is now going to start, which will be performed by our teacher of teachers, Padma Shri Dr. Shanti Roy Madam, along with Dr. Alka Pandey Ma'am, past Vice President East Zone Foxy, co-convener PPH Conclave 2024. Assisted by Dr. Poonam, a senior resident NMCH, and junior residents Dr. Khushbu and Dr. Ritwija.
What is the case, please?
Madam? Madam, please.
Hello. We have assembled here to do one cesarean followed by internal iliac artery ligation, which we will be showing to you. And I hope everything will be okay. The cesarean is going to be done just now. When the uterus gets stitched up, then we will do the internal iliac artery ligation only to show you. Thank you.
So, since we have a few minutes of time left, uh, may I take the permission of Dr. Vinita Singh ma'am to have a video session of Dr. Deepak Desai again? Sir, Dr. Nalini Mishra ma'am, are you here? President ISOPAB, sir, please come on the dais to chair the session. And we'll quickly have the session of Dr. Nalini Mishra, madam.
A very, very good morning to all the beautiful ladies and gentlemen of Patna. I'm really so much thankful to the organizing committee for giving me this opportunity to come here and talk to all of you. और जो बात इनविटेशन से ज़्यादा है वो है आप सबका जो अफेक्शन है और जो आपकी हॉस्पिटैलिटी है. So huge round of applause for Patna Obs Gynae Society. Can I have my presentation, please? Or while they are loading my presentation, I am really lucky to have the chairpersons of the stretcher of Dr. Paul, Dr. Maji, and Sheila Mane ma'am. She is the inspiration of my innovation. So she called me to Bangalore. I saw Temponad for the first time there. Then I went back to Raipur and then we made certain changes and we made it what it is. So maybe many of you are using it. So
I think all of us, we know Dr. Nalini earlier was a professor at Raipur Medical College, and I think now she is the dean of which medical college?
Madam, it's LN Medical College. It's the biggest private medical college of Central India.
Of Central India, that is in Bhopal.
So we have 250 MBBS and 158 PG seats.
Yeah, and she continues her work, and recently she has again published a paper where she has compared the clot observation test with the levels of fibrinogen. And I think that has been recently published, which I can share with all of you. So she is really into research, and all of us are aware about the Chhattisgarh balloon. And not only that, you know, she has also innovated a plastic drape for the blood collection. The plastic apron which we have in labor room, we can just seal it and use it, and it becomes very easy. You just hold the plastic apron and seal one of the end, and then you
I think my presentation is, I loaded it in the morning. Should I bring another pen drive? Okay, so very kind words by Sheila Mane ma'am. And while they are loading the presentation, I can tell you that the CG drape and CG balloon and one more easier way of making a conventional condom balloon tamponade, the easy balloon, they are all available on YouTube, and I can share the link. And if you just type the low cost innovations for diagnosis and management of PPH, then it will appear. So there are many videos on this thing, yes. So full screen cover. Full screen cover. Okay, so when we talk of PPH, everybody knows that what a killer PPH is. It kills one woman every 6 minutes. And the uterine balloon tamponade is one of the key component in the management of this postpartum hemorrhage, which is atonic in 80% of the cases. So we all know the definition of PPH, maybe quantitative, qualitative, but whenever a skilled birth attendant feels that the bleeding is excessive and worrisome, that is PPH. So this I was talking about the Chhattisgarh drape, and it is prepared from the plastic apron which is available, which is supplied in the delivery kit. So you can just seal the lower margin and you can make it, and it's available on the YouTube. It is prepared there at the point of care. It's not a commercial device, so you can prepare it. It costs only 15 rupees, and after the use you just have to send it in the yellow bag for incineration. So it's very, very eco-friendly also. Once the PPH is diagnosed, we have to go for the PPH care bundle by WHO. So all of us know what is this motive. Motive: M for uterine massage, O for oxytocic agent, T for tranexamic acid, and IV for isotonic crystalloids. So it's always a teamwork. I won't be going into detail because I have to show the videos also, but the obstetrician is the team leader. जैसे ही bleeding शुरू होती है डिलीवरी के बाद, रिफ्लेक्सली आपका हाथ सुप्राप्यूबिक एरिया पे जाना चाहिए, यूट्रस वहाँ है कि नहीं, और अगर है तो उसकी टोन कैसी है. एंड इफ इट इज एटोनिक, which is the case 70 to 80% of the time, start massaging, and then you don't leave the patient, you start shouting, you start giving instructions, and everybody else, at least 2 to 3 persons, whosoever is there, they come to help you. And this video I am not showing because I have many more videos. So once this first care bundle of motive, massage, oxytocic agent, tranexamic acid, and this you are continuing, at the same time you have to ensure that the bladder is evacuated. हमेशा catheterize करवाना ही है. Then you rule out the traumatic causes कि वहाँ tear तो नहीं है और retained products तो नहीं है, any placenta or clots, then you have to rule that out. Even if in spite of all this, if the patient is bleeding, you have to escalate. Escalate, आगे जाना है. आगे जाना means क्या करना? We have to go for the bundle 2, and the bundle 2 is the refractory PPH bundle. So what is that? When the bleeding which doesn't respond to initial treatment, it has to have the additional set of intervention, and that is bundle 2. क्या है bundle 2 में? इसमें there are 2 compressions and 2 devices. 2 compressions are bimanual uterine contraction, compression. हम सबको पता है कैसे करना है. हाथ दर्द करने लगते हैं उसमें 2 मिनट के बाद. Then if the patient is bleeding excessively, manual aortic compression, very, very important. While you are preparing for the these devices and all, you just do the manual aortic compression. Then the intrauterine balloon tamponade and non-pneumatic anti-shock garment. So this is as per the recommendation of WHO FIGO, huge evidence base. Why tamponade? क्यों tamponade की बात क्यों करती हैं सारी bodies? इसलिए because there has been a systemic review and all the conservative surgical methods, second line interventions were found to have the efficacy at par. ये सारी चीज़ें बराबर इफेक्टिव हैं. तो कॉमन सेंस क्या कहता है? जो भी चीज़ सबसे कम इन्वेसिव हो, सबसे आसान हो और सबसे इफेक्टिव हो, इक्वली इफेक्टिव, you have to go for that. So that's a basic simple common sense, and it has a huge, huge recommendation by all the authorities across the world to be medico-legally safe. Then what is the basic method of creating tamponade? Basically क्या है? एक गुब्बारा है, एक बलून है जिसको हम यूट्रस के अंदर डालते हैं, इन्फ्लेट करते हैं और उसको वहाँ रखते हैं 6 to 24 hours, and then you deflate it, so it compresses the bleeding sinuses. Or there are other mechanisms also, won't be going into detail of it. But if the bleeding stops, we say tamponade test positive. Patient has responded, so tamponade test positive. If she doesn't respond and continues to bleed, then that's a negative tamponade test, and you have to go for further treatment, maybe the surgical intervention. अब सवाल ये आता है कि कब यूज़ करना है, क्यों करना है, ये तो समझ में आ गया. कब यूज़ करना है? कैलिफोर्निया मैटरनल क्वालिटी केयर कोलैबोरेटिव कहता है कि जब obstetric shock index more than 1 है but less than 1.5, has crossed 1 but has not yet progressed to 1.5 is the ideal time. We'll see what the OSI is. FIGO in its guideline of 2022 says that it is very effective before, when it is placed before the onset of advanced shock. So what is this obstetric shock index? हमको बहुत लोगों को पता भी है, सीधे सीधे याद करने की बात है कि हार्ट रेट अपॉन सिस्टोलिक बीपी, कितना पल्स चल रही है, कितना सिस्टोलिक बीपी है. अगर पल्स 90 है, सिस्टोलिक बीपी 110 है, तो आप OSI लेस देन 1 है. नॉर्मली ऑब्स्टेटिक्स में 0.7 to 0.9 है नॉर्मल वैल्यू. If it is crossed 1, so that is not normal. If it is crossed 1, that means the patient has lost more than 1 liter or 15% of her blood volume. If it is more than 1.5, then the patient has lost 1.5 liters or more than 30% of her blood volume. तो हमको UBT ideally कब डालना है? When it is between 1 to 1.5. So ideally, किसी भी time you are doing the first line management, the pulse crosses the systolic BP. आपका एनेस्थेटिस्ट, आपका हेल्प जो वहाँ पर लेबर रूम में, वो कहते हैं मैडम बीपी ठीक है, 100 है सिस्टोलिक, 110 है. आप उससे पूछिए कि पल्स कितनी है. इफ द पल्स इज 120, 130, so that is OSI more than 1. क्यों? Because of the changes in the pregnancy, physiological changes, when before the fall of the systolic blood pressure, heart rate rises, and thus the obstetric shock or the shock index increases. So always consider pulse and systolic blood pressure ratio. सीधा सीधा. So टेम्पोनाट कौन सा, क्यों करना, कब करना, कौन सा करना, बहुत सारी चॉइसेस है हमारे पास. कमर्शियली अवेलेबल भी हैं और कुछ हैं जो हम खुद बना भी सकते हैं. तो यूट्राइन स्पेसिफिक बलून टेम्पोनाट डिवाइसेस हैं. कॉमनेस्ट यूज इज बकरी बलून. ऑल दीज हैव ड्रेनेज चैनल. जो दूसरी है लावी, ASM, UBT, इन सब में ड्रेनेज चैनल नहीं है, सेंट्रल ड्रेनेज चैनल नहीं है. अब लो रिसोर्स सेटिंग में साहिबा अख्तर जी ने बनाया था कन्वेंशनल कॉन्डोम बलून टेम्पोनेट. उन्होंने तो रेड रबर कैथेटर के ऊपर कॉन्डोम लगा के उसको बांधा था, और हम बनाते हैं, अभी तक बनाते भी थे, लेकिन उसमें थोड़े से प्रॉब्लम्स आते हैं. हम उसको धागे से या किसी भी सूचर मटेरियल से बांधते हैं. मान लीजिए दैट knot is loose, then this saline leaks, so your patient is bleeding and your balloon is leaking. आपने बोला अच्छा ऐसे कैसे लीक होगा, टाइट कर दिया, so we practically strangulate it, then the saline will not go inside and there is no drainage channel. तो हमने कहा कि ठीक है, हम लो रिसोर्स सेटिंग है, और अगर हमारे पास बकरी बलून खरीदने के लिए पैसे नहीं है, और अगर होते भी तो हम नहीं खरीदते, क्योंकि हमने अपने जुगाड़ से देसी बकरी बलून बना लिया. उसका नाम है छत्तीसगढ़ बलून. आप उसको बना सकते हैं, बहुत सारे लोग यूज़ भी कर रहे हैं अक्रॉस इंडिया एंड सो मेनी पार्ट्स ऑफ द वर्ल्ड ऑल्सो. आप उसको बना लें, क्योंकि स्टेप्स थोड़ा याद करनी पड़ती है. उसको ETO करवा लें, जो आप देख रहे हैं राइट साइड में, ये लेफ्ट साइड में ETO करवा के रख लें लेबर रूम में और OT में. तो दिस हैज़ बीन पब्लिश्ड बाय फीगो हाउस, IJGO, in our own Jogi, and I'm really happy to share that it has recently been cited in the FIGO recommendation 2022. So how do we make it? हमको क्या चाहिए? फोलीज कैथेटर, एक चीज़ का ध्यान रखना है कि थोड़ा सा बिगर फ्रेंच का लेंगे 2022-24 का. अदरवाइज आपके पास जो उससे भी बना सकते हैं, बट प्रेफरेबली 22. कॉन्डोम चाहिए, सीजर्स और सिरिंज चाहिए. हम देखेंगे कैसे बनाते हैं. तो ABCD से इसको याद रख सकते हैं. यूट्यूब पे वीडियो अवेलेबल है. A is for air, so inflate at least 10 ml of air in the bulb of the Foley's catheter, because we are going to replace the bulb of the Foley's with a bigger bulb which is made of condom. अब इसको आप, you can wound it around your finger and just cut it with the scissors. So पटाखे जैसी आवाज़ आएगी फट से. Then आप scissors का एक आर्म उसमें डालिए and cut दिस ऑल अराउंड. ये जो हमने छेद बनाया था, इसको चारों तरफ काट लीजिए. फिर जो अपर फ्लैप है उसको ऊपर रिवर्ट कर दीजिए, और नीचे वाले फ्लैप को नीचे कर दीजिए. द आइडिया इज टू एक्सपोज द होल जो शेफ्ट के ऊपर है, बल्ब के एरिया का जो होल है, क्योंकि इससे हमको सलाइन इन्फ्लेट करना है. नाउ इन द प्रॉक्सिमल पार्ट ऑफ दिस फोलीज कैथेटर, रोल द कॉन्डोम. तो उसको राइट हैंड से उसको टिप को पकड़ लीजिए कॉन्डोम के साथ और उसको जेंटली रोल कर दीजिए. ये हो गया बी फॉर बल्ब, सी इज़ फॉर कटिंग। अब हमको सूचर मटेरियल नहीं यूज़ करना है, तो हमको रबर बैंड बनानी है, जो हम फोलीज कैथेटर के यूरिनरी ड्रेनेज पोर्ट से हम रबर बैंड पतली पतली काटेंगे। देन डी इज़ डबल एप्लीकेशन, तो पहली रिंग उठाएंगे और उसको नेक पे लगा देंगे हम, जहाँ पर बल्ब था वो उस बल्ब की जगह हम अपर पोर्शन में पहली रिंग को लगा देंगे। तो ये डबल एप्लीकेशन ऑफ द फर्स्ट रिंग, ये देखिए कि वो होल के ऊपर नहीं आ जाए। और सेकेंड रिंग को हम लगाते हैं 1.5 to 2 सेंटीमीटर्स अवे फ्रॉम द डिस्टल एंड। ये ध्यान रखें कि ऐसा ऐसा मुड़ना नहीं चाहिए, जो कैथेटर है दैट शुड रिमेन स्ट्रेट। तो ये हमने लगा दिया लोअर पोर्शन में। सो दिस इज डबल एप्लीकेशन ऑफ द रिंग। तो ये रिंग आपको सस्ती है क्योंकि यहीं इसी में से हमने काट ली है। नाउ यू कट, ई इज फॉर एक्सीजन, ए बी सी डी ई, एक्साइज the upper portion of the condom and catheter together at the middle of the urinary drainage hole। अब ये टॉप से आपका ड्रेनेज होल बन गया, सेंट्रल ड्रेनेज होल। तो ये आपका बन गया इसको, बिकॉज ये कॉन्डोम जो है इट इज़ पैक्ड अंडर हाइजीनिक कंडीशन, स्टेराइल नहीं होता, इसलिए हमने इसको 3 मिनट तक के बिटाडीन सोल्यूशन में डाल के रखते हैं। एक सलाइन की बॉटल को खोल लीजिए, ये छत्तीसगढ़ ड्रेप है आप देख रहे हैं, इसमें 1 लीटर के करीब ब्लड लॉस हो गया है। और दो you take 2 big speculums and catch hold of the anterior and the posterior lip of the cervix। So take big speculums should always be kept there in your PPH tray, and always prepare a PPH box। Now take out this CG balloon and this just insert it, it goes very easily, it goes inside जब तक कि उसका जो रिंग है वो आपका अपर पोर्शन ऑफ द ऑस में दिखने लगे। So this is done, and then you just connect the urinary drainage port, and before that we can pack the vagina। ये इसका सबसे बड़ा एडवांटेज है क्योंकि हमको ऑनगोइंग ब्लीडिंग जो है वो ऑस पे या वेजाइना में देखने की ज़रूरत नहीं है, हमारे पास सेंट्रल ड्रेनेज पोर्ट है, इसलिए हम वेजाइना को पैक कर सकते हैं। अदरवाइज कन्वेंशनल कंडोम बलून टेम्पोनाट में क्या होता है कि हम जब इन्फ्लेट करना शुरू करते हैं तो 100-150 के बाद वो बाहर आना शुरू हो जाता है। यहाँ पर हमने पैक कर दिया, सो इट इज़ नॉट एक्सपेल्ड। नाउ थ्रू द बल्ब इन्फ्लेशन पोर्ट, बिकॉज वी हैव रिप्लेस द बल्ब ऑफ द फोलीज विद a bigger bulb which is made of condom, so we'll be inflating through the bulb inflation port। now take the syringes alternatively, syringes से इसलिए डालना पड़ेगा क्योंकि पॉजिटिव प्रेशर से डालना पड़ेगा, जैसे हम फोलीज को इन्फ्लेट करते हैं उसी मेथड से ये इन्फ्लेट होगा। तो एक हमने सेलाइन की बॉटल ऊपर से खोल के रख दी थी, maximum arbitrary amount is 500 ml, and you can see the ongoing bleeding। now the bleeding has stopped, so the column has stopped moving or the bleeding is less than 1 ml per minute। तब हम कहते हैं कि ये बंद हो गया, hemostasis हो गई। आप देखिए the balloon is inside the uterus, and after that you catheterize the woman, give her 1 dose of antibiotic, mark the margins of the uterus, and then put her on oxytocin drip for 4 to 6 hours। then after that you can stop and you can रिमूव। ये अच्छा सिजेरियन सेक्शन में है, ये प्लेसेंटा प्रीविया की पेशेंट थी और यू विल सी दैट शी हैज़ बीन ब्लीडिंग हैवीली। ये प्लेसेंटा निकालने के बाद एंड देन देयर वाज सो मच ऑफ ओजिंग फ्रॉम द लोअर सेगमेंट ऑफ द यूट्रस इन स्पाइट ऑफ वो ऑक्सीटोसिक्स वगैरह दिए, बट एज यू नो इट वाज फ्रॉम द लोअर यूट्राइन सेगमेंट, इट वाज नॉट रिस्पॉन्डिंग। सो we went ahead with putting in the Chhattisgarh balloon। so this is put through the uterine incision, and then the lower portion is traversed out through the cervical canal through the vagina by an assistant, and then you just inflate it to 50 ml or so, and then you can close the uterine incision and then inflate it further till the blood column stops moving in the drainage port of this thing, urosec, and then you close the abdomen once the hemostasis has been achieved। so that is how we use it in a cesarean section। during cesarean section it's your choice whether you want to go for the compression sutures or you want to go for balloon tamponade, but after vaginal delivery balloon tamponade is more practical because you don't have to go for laparotomy in 86% of the instances। so how do you deflate? 6 to 24 hours लेटर। कई लोग कहते हैं कि कैसे निकालना है, 50-50 ml करके निकालें, कुछ नहीं करना है, इसमें एक नीडल डाल दीजिए। आपको याद होगा रेसिडेंसी के टाइम पे जब कभी कभी वो सरकारी वो निकलते नहीं थे कैथेटर्स, तो हम इसमें नीडल डाल के रख देते थे, वो धीरे धीरे सेलाइन डिफ्लेट हो जाएगा। आप उसमें एक नीडल डाल दीजिए, किडनी ट्रे में रख दीजिए, राउंड पे चले जाइए, जब तक लौटेंगे आधे पौन घंटे में सारा सेलाइन बाहर आ जाएगा। यू टेक आउट द वेजाइनल पैक एंड दी सीजी बलून विल कम आउट, सो लाइक दैट। और रिकरेंस अगर हो तो पैक मत निकालिए। आज तक हमें कोई रिकरेंस नहीं मिला है, वी हैव यूज्ड एन नंबर ऑफ दिस थिंग। अब कहते हैं कि भाई ड्रेनेज पोर्ट क्यों चाहिए, कई लोग कहते हैं ड्रेनेज पोर्ट की ज़रूरत नहीं है। ड्रेनेज पोर्ट इसके लिए तो सर यूनुस बकरी ने खुद लिखा है इंटरनेट पे कि इट्स ए brilliant solution because we got to know that the tamponade test is positive or not. दूसरी बात, मुझे किसी ने जो यूज़ कर रहे हैं लखनऊ में, शायद किसी ने मुझसे बोला था कि मैडम ड्रेनेज से हमको ये पता चलता है कि हाँ अब ये ब्लीडिंग बंद हो गया एंड वी फील मोर कॉन्फिडेंट। तो ये बात तो सच है। और यू कैन पैक द विजाइना while inflating, so it's a diagnostic as well as therapeutic tool. अगर मान लीजिए डालने के बाद भी ब्लीडिंग हो रही है, इसका मतलब कि आपको आगे जाना है। तो अगर कमर्शियल वर्सेस सेल्फ मेड में हम जाते हैं तो हम क्यों खरीदेंगे जब हम खुद वो काम 50 रुपए में कर सकते हैं या 100 रुपए में, तो हम 9,000 की चीज़ क्यों खरीदेंगे। हम भारतवासी हैं, हम जुगाड़ कर लेते हैं। तो हम सेल्फ रिलायंट है। और इसका कॉस्ट इफेक्टिवनेस के लिए एक मेटा एनालिसिस हुई थी जिसमें छत्तीसगढ़ बलून वाज फाउंड टू बी द लीस्ट कॉस्टिंग डिवाइस। इवन ये कन्वेंशनल कंडोम बलून टेम्पना से भी सस्ता पड़ता है, क्योंकि कन्वेंशनल में भी आप यू विल टाई इट विथ समथिंग ना। सो नाउ इट इज़ नोबडी यूजेस थ्रेड, तो थ्रेड तो किसी के लेबर रूम में होता नहीं है। क्लिप्स लगाते हैं हम अम्बिलिकल कॉर्ड में भी। अब ये आप सिल्क लगाएं या एक वाइक्रिल खोलें तो वो 300 रुपये का पड़ेगा। इससे अच्छा रबर बैंड वहीं से काट लीजिए फोलीज में से, उससे बांध दीजिए तो आपका सस्ता पड़ेगा। सो दिस देयर आर सम कॉन्ट्राइंडिकेशंस। एलर्जी टू लेटेक्स मुझे आज तक मिली नहीं, बट जो भी है इन्फेक्शंस हो या मालफॉर्मेशंस हो या रप्चर हो तो या आर्टीरियल ब्लीडिंग हो, देन वी डोंट गो फॉर दिस। एंड कॉम्प्लिकेशंस आर वेरी रेयर इन केसेस ऑफ प्रीवियस सिजेरियंस ओनली, एंड लॉन्ग टर्म सेफ्टी इज़ देयर। ये एक सैंडविच सर्जरी है जिसमें वी कंबाइन दी बलून टेम्पोनाड विथ कॉम्प्रेशन सूचर। तो जिनमें अकेला टेम्पोनाड या अकेला बीलिंच नहीं इफेक्टिव होने वाली हो, जैसे ये केस थी कि इसमें शी वॉज अ ग्रैंड मल्टी एंड वेरी एनीमिक और यूट्रस एकदम फ्लैबी था। हमने कॉम्प्रेस करके जब देखा था तो ब्लीडिंग फिर भी हो रही थी। सो हमने पहले एक ओरिजिनल क्लासिकल बीलिंच सूचर डाला, उसके बाद उसके अंदर हमने टेम्पोनाड डाला और फिर पहले बीलिंच को टाई किया। बीलिंच को टाई करने के बाद अभी ये आप देख रहे हैं, अभी तो ब्लीडिंग हो रही है। बीलिंच टाई करने के बाद हम यूट्रस को क्लोज किया और यूट्रस क्लोज करने के बाद हमने फिर देखा कि कितनी ब्लीडिंग है। तो यूट्रस जब क्लोज करते हैं तो वी हैव टू टेक केयर दैट वी डू नॉट पंचर दी बल्ब ऑफ दी दिस थिंग। सो यूट्रस इज क्लोज्ड। पहले से ही हमको एंगल पकड़ लेने चाहिए हमेशा जब भी बीलिंच लगाते हैं, सो दैट इट इज़ नॉट दे डू नॉट गेट इन्वर्टेड। तो ये हो गया। अब हम देखेंगे कि कितना ब्लीडिंग है। सो ये सूचर क्लोज हो गया, यूट्राइन इंसिजन क्लोज हो गया, बीलिंच सूचर टाई हो गया था। ओ ब्लीड कर रही है, ये दिस इज द एडवांटेज ऑफ ड्रेनेज पोर्ट। देन विल इन्फ्लेट इट फर्दर जब तक के ब्लीडिंग नहीं बंद हो। इसमें हमको करीबन 280 ml डालना पड़ा था एंड देन द ब्लीडिंग स्टॉप्ड, सो द हिस्टेरेक्टमी कुड बी सेव्ड। सो दिस इज व्हाट इट इज़। एक्सटेंडेड यूज़ हम कर सकते हैं। हमने इसको यूज़ किया है रिकरेंट यूट्राइन इन्वर्शन में। पहले हम वो लगाते थे, एक बहुत लेंदी प्रोसीजर होती थी, VNY सूचर्स, पता नहीं बहुत सारे मल्टीपल सूचर्स। उसके बाद एक पेशेंट थी जिसमें रिकरेंट इन्वर्शन हो रहा था, उसमें हमने एक बार करेक्शन करके ये डाल दिया, नेक्स्ट डे रिमूव किया, देन देयर वाज नो इन्वर्शन और रिकरेंस ऑफ द इन्वर्शन। एंड इन जैसे कभी हेपेटाइटिस ई या ए का एपिडेमिक आता है, उस टाइम आप बहुत सारे ड्रग्स नहीं यूज़ कर सकते, तो आप प्रोफाइलेक्टिकली यू कैन पुट इन द टेम्पोनाड। हमारे यहाँ अभी एक पेशेंट डिलीवर हुई थी, शी हैड सबम्यूकस फाइब्रॉइड एंड शी वाज ब्लीडिंग। तो उसमें भी हमने ये डाला बिकॉज दिस इज़ वेरी सॉफ्ट, सो इट टेक्स द शेप ऑफ द यूट्राइन कैविटी एंड वी कुड स्टॉप द ब्लीडिंग। ये थी एक ट्रॉमेटिक पीपीएच में, अपेक्स ऑफ वेजाइना में टेयर था, रेफर होके आई थी पेशेंट। जितना भी सूचर ले रहे थे, सर्जिकल रिकोर्स इज ऑलवेज द फर्स्ट मेथड इन ट्रॉमेटिक पीपीएच, बट इसमें जैसे ही सूचर ले रहे थे तो इट वॉज सो वेस्कुलर एंड फ्राइबल दैट इट वॉज ब्लीडिंग मोर एंड मोर, सो वी पुट इन दिस टेम्पोनाड एंड रिमूव्ड इट 24 आवर्स लेटर एंड पेशेंट वॉज फाइन। एक Cloud9 हॉस्पिटल बेंगलोर में एक स्टडी हुई, नॉट ऑब्स्टेटिक्स बट नॉट पीपीएच बट ऑब्स्टेटिक्स। ये एक उनकी प्रेशियस प्रेगनेंसी की पेशेंट थी, शी केम एट 22 वीक्स ऑफ जेस्टेशन, सर्विक्स 4 सेंटीमीटर डायलेटेड था, मेम्ब्रेन्स वेयर प्रोलैप्सिंग। तो इन लोगों ने दे रूल्ड आउट द इन्फेक्शन एंड दे वांटेड टू गो फॉर अ रेस्क्यू सर्कलाज। अब वो मेम्ब्रेन्स जो बल्ज कर रही थी वेजाइना में, उसको कैसे ऊपर करें, तो फॉर दैट दे हैव यूज दी छत्तीसगढ़ बलून एंड बिकॉज एज यू इन्फ्लेट इट ना, तो इसका टिप जो है वो अम्प्लीकेट हो जाता है, सो इट डजेंट कॉज एनी ट्रॉमा टू द मेम्ब्रेन्स। तो इससे उन लोगों ने मेम्ब्रेन्स ऊपर की, सर्कलाज लगाया, इसको डिफ्लेट किया, द प्रेगनेंसी वॉज कैरिड टू टर्म एंड शी हैड अ हेल्दी बेबी। सो दैट वॉज रियली अ नाइस यूज ऑफ छत्तीसगढ़ बलून एंड so the conclusion is it has a huge evidence based and least expertise is required, बहुत ही सस्ता है, very effective and you can use it many places। तो ये जुगाड़ है, हम भारतवासी जुगाड़ करने में बहुत माहिर हैं, so I am proud to be a भारतवासी। Thank you so much, thank you so much chairpersons।
Madam, I think you should stop saying it Jugar. You should say Make in India. No, honestly. It means we do. Why should we say it's Jugar? We've done something at a much lower cost, which we are proud of. We made it in India. So
Okay,
it is
sir.
Make in India. Next time, don't call it Jugar, madam.
Made in Bharat।
Madam, really, you are lucky to see your presentation. The one message is that, and it is everybody knows Dr. Nalini Mishra, the Chhattisgarh balloon. One is that the large amount of fluid can be given with using the condom and to make a drainage system. That one limitation is every balloon till the date. So here it is the combination and the maximum thing is that it is can be used very low resource person and in rural India also and can be made it can be it will be better, it will be also commercially very cheap and can be used. This is a very effective method.
We'll take the questions later. The OT is ready, so we'll go back to the OT. And after Dr. Deepak Desai's talk, we'll take the questions.
Thank you, sir. Thank you so much, sir.
Thank you, madam.
Extended use DIC. I have an experience of using it in cases of DIC. Okay, so because till you make all the arrangements till the blood comes, okay, yeah, you can use. In fact, you know, the moment we used to try to deflate, the patient would bleed. And that patient, it must have been a subclinical amniotic fluid embolism. She was on ventilator, 80 transfusions, 4 gram of fibrinogen, balloon tamponade, anti-shock garment, all was used, patient recovered. Okay, yeah. Another case was a case of jaundice. Again, her INR was 2.4, no question of taking her to OT. So we used anti-shock garment, balloon, correction of DIC. We, that case gave prothrombin complex also because it was a case of jaundice. Another case again, after MRP she started bleeding. We thought, I mean, she went into excessive hemorrhage, into DIC. We had put, she received 30 transfusions and she also survived. So, you know, you have to stop the bleeding, arrest the bleeding.
Yes.
That is the main thing. And if you can use whatever is available, arrest the bleeding is the motto. Thank you.
Thank you so much, ma'am. Thank you so much.
Really proud of you, madam, for such innovation. And let us now move on to OT, where Professor Padmashri, Dr. Shanti Roy, madam, is ready with her internal iliac ligation case, along with Dr. Alka Pandey, madam. So let us move over to OT. Yes, Dr. Meena Samant is there.
थोड़ा सा और एडहेशन है
एनएमसी से बात कर रहा हूँ मैडम.
ये ट्यूब पकड़ा है.
Hello. Hello, Dr. Supriya.
Three forces have.
Am I audible?
Yes, ma'am.
Hello.
So
Hello.
thank you,
Hello.
everyone.
Hello.
Dr. Supriya? Yes, you are audible. Yes.
Heard him, and now again academics, that is extraperitoneal internal iliac artery ligation for central placenta previa by Dr. Deepak Desai. He is a consultant at Virar Maternity Nursing Home, already introduced. Okay, so we are waiting to hear you.
Regarding central placenta previa, when the placenta, you all know, when the placenta is in the lower part of lower segment covering the os, then we call it central placenta previa. These cases should be, see, first one has to know that our limitations. We all know nowadays because of the sonography, we pre-diagnose central placenta previa. If you are able to do internal iliac artery ligation, then only tackle this case. Otherwise, refer it to a center where it can be done. This should be the baseline because central placenta previa, if you see the lower part of lower segment bleeds, is actually can be tackled only by internal iliac ligation, whether it is a trauma or whether it is a placenta situated. So this is the indication for say, internal iliac ligation. So again, I am showing this slide because see the blood supply and this area is, if you try to ligate it, the uterine artery here, the ureter is close by, so that's why you have to ligate it, the internal iliac artery, because first thing is that if you just ligate the uterine, it is not going to get, the blood supply is not going to get hampered because the cervical branches, they come from little away, then vaginal branches also supply the lower segment, so that's why internal iliac ligation is must. Okay. So there are a number of methods of doing conventional internal iliac ligation, like we have a approach to posterior peritoneum through posterior fold of broad ligament, through anterior fold of broad ligament. I am going to show you a easy way of doing an internal iliac ligation, which is extraperitoneal approach. So before that, we have to know the anatomy clearly. So we have to know all the anatomy clearly. So here you can see the common iliac artery is getting divided into external iliac, internal iliac, and internal iliac posterior division and anterior divisions. We are interested in the anterior division. So when you come from above, we have the ureter coming in the way, the external iliac vein and the internal iliac vein, they converge. So when you come from above, all this comes in a way. But if you see the anatomy, the internal iliac artery continues as an umbilical artery and then umbilical ligament. So if you just follow the umbilical ligament, you can go and to the internal iliac. So this is, so just to enumerate all the branches in little different way.
Iliolumbar, lateral, sacral, superior, gluteal, obturator, umbilical, which gives superior vesicle, uterovaginal, middle rectal, inferior vesicle, internal pudendal, and inferior gluteal, branches of arteria, iliac internal, branches of arteria, iliac internal, iliac.
So this was a schematic diagram, and this is a clear-cut anatomical dissection. Recently we had in Indore, so there I could get this anatomy dissected diagram, absolutely fabulous. See here you can see this green color is the obliterated umbilical artery. This is external iliac artery, this is internal iliac artery, divided into
recording in progress.
Yeah. So here this is anterior division. Here you can see the posterior division going there, and here all the branches, like this is umbilical artery. The superior vesical artery, then the inferior vesical artery, and here is the, these are superior vesicle, sorry, superior vesical arteries. They are multiple, and this is the uterine artery. You can see the ureter crossing here. This is a tortuous artery. So this is the clear-cut diagram which I could get it anatomically. See here, this is actually cadaver dissection. In pregnancy, this umbilical artery goes upwards, so that's why it almost comes as a perpendicular to the internal iliac. So when you follow this umbilical artery, you will be able to reach the this anterior division of internal iliac. So for that, see, any surgery you have to have a good instruments. So important thing is like good retractors. Most of the times what we use is a Devers. Devers has got a convexity from a. So because of this convexity, most of the, see, we are operating in a cavity where it becomes a little difficult. So this is our modified Wertheim's retractor, which is very, very useful in all the cavities. And you have to have a good mixture. So mixture also, see, normally what mixture which we use is like which has got a serrations, and that serrations can, when you withdraw the mixture, can damage the internal iliac vein which is just sitting below. So these abrasions can cause bleeding. So you have to have a mixture which has got a catch inside, no serrations. Okay. So what are the advantages? These are reduced chances of complications like injury to ureter, external iliac and all. So we need not externalize the uterus, no need to pack the bowels, no chance of injury to sigmoid mesentery on left side, easy to learn and practice, can be performed quickly within few minutes, and post-op recovery is absolutely fast. Let's see the videos. This was a case of a central placenta previa, no blood available, hemoglobin of 9 grams and a severe bout of bleeding. So here, after doing the cesarean section, I do extraperitoneal cesarean section. So here in the extraperitoneal cesarean section, we are, see, just to get oriented, this is a left side, right side, cranial and the caudal. So let's see. So here, go between the rectus muscle and the peritoneum, and you can easily be able to find out the medial umbilical ligament. Medial umbilical ligament is the lateral summit of the bladder. You catch it. It is an obliterated umbilical artery, and just a finger dissection, and you can go down, and you will be able to go to the base of the umbilical artery, and that is internal iliac artery. So here you put a retractor and you will be able to see the umbilical artery. So this is umbilical artery you are seeing, internal iliac anterior division. Just a blunt dissection and you are there without much blood. There will not be any blood loss. So you have to, only thing is, important thing is that when you dissect, see to it you are not dissecting caudally, dissect it cranially. So there are no blood vessels there. So there is there are no capillaries or vena comitatus. You go down, there is a vena comitatus. So there the chance of bleeding is there. So you just dissect cranially, and there will not be any capillary ooze also. So here you can see, appreciate that there is nothing. And now you can make fenestrations. So here again, making fenestration is also easy because the thick fascia is only up to this level. Below that, there is a loose connective tissue. The thick fascia is mainly made by nature to keep the vessel in, because the posterior division goes in the canal. So there, up to that level, only the thick fascia is there. Below that, the vessels are moving because the bladder vessels are there, the uterine vessels are there, where the organs are moving. So there is no thick fascia there. So it can easily make the fenestrations. And then you can pass the mixture from lateral to medial side. The mixture here is a little sigmoid shape, so it can be easily passed like. It takes hardly 2 minutes to reach the internal iliac. Just to show you all the vessels, See here you can see this is the umbilical ligament, umbilical artery, which will give superior vesical vessels. You can see the superior vesical vessels coming. This is the thread on the internal iliac, and this is the continuation of the, rather on this juncture, all the vessels like uterine and vesical, inferior vesical, all they come from this angle. So you have to just follow this, go to the base, go little upwards and ligate it. You are 100% sure that you will ligate it after the posterior division is given. I'll show you here the posterior division. I'll show you. This is just to see the anatomy. We usually prefer to take only one stitch. Ideally, one can ligate it here also. That will be the selective ligation here, because when you ligate after the umbilical, then we can save the superior vesicles also. So blood supply to the bladder will not get hampered. So up till now you have not seen the ureter also. External iliac artery is also away. See, you can see here is the external iliac artery, quite far off. It doesn't come in your way, and here is the ureter passing at the juncture. So when you go lower down, there are no vessel, no complicated structures which can be seen. So here you can see I am dissecting out to show the posterior division. So here it is the posterior division. So here when you come from above, you have to calculate 3 centimeter, 4 centimeter. But here you 100% you are sure that you will be ligating after the posterior. Here you can see the posterior division. So let's go on the other side now. Now we'll go on the other side. Again, identify the median umbilical ligament, hold it. I have held the umbilical ligament, and now I'll be dissecting at the base of it. So only thing is dissection should be cranially, not caudal. So this is the cranial end, this is caudal end, this is left side of the patient, this is right side of the patient. So here again I am making dissecting, and just put the retractor, pull it upwards, and you will be able to identify the internal iliac anterior division. See here now. See, it is easily seen the anterior division. So we have held the umbilical ligament, and you can see the internal iliac vein will be sitting posteriorly and laterally. So here you will be able to identify it. See here. So here it is the posterior, internal iliac vein. So when you come down, the internal iliac vein is also little on the lateral side. So because so that's why it is not possible to damage it like. So when you are up in the upper part, the chance of injury to internal iliac vein could be there like. So here now I have to pass the mixture from lateral to medial. When you pass from lateral to medial to lateral, there is a chance of damaging the internal iliac vein. So here you can see umbilical artery, umbilical ligament, umbilical artery, pass a thread. A sigmoid shaped mixture works very well for maneuvering. Here again the anatomy will be clear. I will show you all the vessels there. So now umbilical artery, the internal iliac anterior division, internal iliac vein, the external iliac vein here, the external iliac artery here, external iliac artery, external iliac vein there. So when you come from above, all this gets converged, and that's why you come across all these vessels from below. So the actually umbilical artery is actually a continuation. The internal iliac artery continues as an umbilical artery. So here you can see the ureter is quite far off. So this is the let's see another case. I think I have time, no? So here This is another case of a central placenta previa. You can see, appreciate that there is a central placenta previa. If it comes out easily, you remove it, otherwise, no. Most of the times it comes out easily unless it is accreta and percreta and all. But usually central placenta previas are not no accretas and all. So most of the times that anterior placenta with a caesarean incision, there is something. So here we are removing the placenta and then get the uterus out. And close it fast, and then immediately you go for a ligation of the, see here I have closed the uterus, and now I will be doing the lateral stitch, because as I told you, interiliac artery will not work, ligation will not work unless you close down the ovarian axis. So here we are taking the ovarian axis, and in case of placenta previas, either a central or even a grade 1 and 2, so there you take the chunk more of the uterine chunk also. Musculature भी ज़्यादा लेना है, जितना बीच में खाली एक 1 inch का gap रख के दोनों बाजू से, तो most of the lower segment is also obliterated. As I told you that we keep on giving saline wash so that uterus can remain contracted well. So इसके लिए वो करते हैं. Yeah, 10 millimeter. ये चालू है, central placenta के चालू है. So here now, after removing the placenta, I took a lateral stitch. तो lateral stitch में थोड़ा मैं पीछे ले देता हूँ. एक मिनट, मैं बैक वापस जा रहा हूँ. Because central placenta previa में ये important है कि you take the, I'll just keep on. So here, after closing the uterus, you take stitch on the lateral aspect of the uterus. So that is very important, and then go for a internal iliac. So here again, I'll show the internal iliac only here. So here I'm showing you how to take the lateral stitch. So here I'll be taking the lateral stitch on the lateral aspect of the uterus, so that the main blood supply to the lower segment will get reduced, the ovarian axis. So here we take a bigger chunk and then go from lateral, take larger musculature, and this will obliterate at least 50% of the blood supply coming to the uterus, and then you go for an internal iliac. So here we are taking this stitch. This is a little broader stitch. ये होने के बाद में internal iliac. Again here you can see. So here go between the peritoneum and the rectus, pierce the transversal fascia, and you will be able to identify the median umbilical ligament. Once the median umbilical ligament is seen, you just follow it to the base. And put the retractor upwards, dissect it upwards, and the internal iliac artery is in the view. So in case of central placenta previa, when you after removal of the placenta or before the removal of placenta, you can take lateral stitch, remove the placenta, and then go for the internal iliac. So for a central placenta previa, internal iliac artery ligation is must. Even the placenta separated very well, bleeding is less, but then the
Recording in progress.
So here you can see the internal iliac artery has come in the view. This is the umbilical artery here, the internal iliac artery here, the external iliac artery here. So here is the internal iliac artery. Here is the external iliac vein. So here I am making a fenestration again. So the fenestrations have been made. And now I will pass a mixture from lateral to medial aspect. In this case, I am showing that ligation after the umbilical artery. So how to approach that? So that the vessels, the umbilical artery will be saved, so the superior vesical arteries will be saved. So here, as usual, I have taken a thread above the umbilical artery on the internal iliac, and then I'll go below the umbilical artery and come back downwards, so that I will be able to ligate it. See here now, this is a regular one. If I want to do it selectively, then I can go below the umbilical artery, come below, and then ligate it. So this is a cranial end here. So here now I am going below the umbilical artery, getting that end below the umbilical artery, and I am not doing it directly, because if I start dissecting lower down, there is a chance of venules getting injured. So here I have done it selectively, the internal iliac artery ligation of the rather uterine artery ligation, you can call it. So yeah, yeah. This is last step. Okay.
Wind up. I think we're excellently shown. The video is, I mean, clearly seen. The anatomy is very well explained, and I think the doubts were very much clear.
Just to show you, see, this was the end result. There is no bleeding at all. So that's usually what you see.
Only one query is,
yes,
suppose if it is following a cesarean, you are doing an extraperitoneal cesarean, but everybody is not doing.
Yeah.
So certain situations.
Second section was in transperitoneal only.
Okay, transperitoneal only.
So see, it is approaching is very easy. Whether it is in transperitoneal or extraperitoneal, you have to go between peritoneum and the rectus, identify the median umbilical ligament. Once you identify median umbilical ligament, job is simple. So in a routine cesarean sections, keep on identifying median umbilical ligament. Once you get used to it, go to the base.
Good. That's a good take-home message and a good point.
Practicing
Yeah.
is very easy. So
Thank you. Thank you so much.
Thank you, Deepak. I think very important message when you are passing your mixture, go from lateral to medial. Because there's not only the internal iliac vein, there's also the external iliac vein. And the external iliac vein injury is even worse. So always put your mixture lateral to medial. I think what is great is we've seen two different techniques of internal iliac. We've seen Shanti Roy madam do by the lateral approach. We've seen you do by the extraperitoneal approach. Let us hope that somebody will show us the posterior approach also today. Thank you, Deepak. I think we go back to the hospital for a short inauguration first.
Yeah, and one announcement. Anybody interested in learning extraperitoneal cesarean section, extraperitoneal internal iliac ligation is welcome at my house. We are a free workshop, so especially for the young generation, come anytime to Bombay.
And you will get a very good packet of cashews from his own farm.
So thank you very much, sir, for this brilliant presentation. And all of you must attend the hands-on training in the evening, which will be held at Hall Kautilya from 5 p.m. to 7 p.m., where all these mg comox suture and all the sutures and internal iliac ligation and uh, Chhattisgarh balloon catheter, everything will be shown by our experts, Dr. Mahesh Gupta sir, Dr. Nalini Mishra ma'am, Dr. Shashi Kabra ma'am, Dr. Sheila Mane ma'am, and Dr. Samarth Ram and Dr. Poonam Dikshit ma'am. So it is now time uh, so that is really very important, the hands-on training by the hands of all the leading personalities of India in the PPH world. So there are 6 workstations from 5 to 7 p.m. At Kautilya Hall. So all of you must attend that for the practical tips. And Foxy PPH Conclave headed by Dr. Vinita Singh and uh, co-chaired by Dr. Supriya Jaiswal and Dr. Veena Sinha is ready with the inauguration of workshop at NMCH auditorium. So we will have a live telecast from there, the inauguration of Foxy PPH Conclave workshop. So kindly connect to NMCH auditorium where Dr. Supriya Jaiswal is there.
Very nice, wonderful video session and the live session of this PPHCon workshop. We a very good afternoon to all of you and warm greetings from team workshop committee to all of you who have gathered here, all the delegates, all the faculty members, respected seniors, friends and juniors. So we start with the year. We have just called upon the dais. We have Dr. Vinita Singh, Chairperson Workshop Committee, Chief Guest Padma Shri Dr. Shanti Roy Madam. As guest of honor, we have Dr. Mahesh Gupta sir, who is the National Advisor PPH Con 2024. Then Dr. Alka Pandey Madam, who is the co-convener of this PPH Con. Dr. Usha Kumari, who is the principal NMCH. Dr. Alka Sinha, Madam, who is the superintendent of NMCH. Dr. Saroj, Deputy Superintendent NMCH. So all have come on the dais and we have all kindly give the floral welcome. May I request all of you to come and sit on the dais and give a huge round of applause to them. So to just formally give a welcome address today, this is a very, very interesting, important workshop being done here. Although little bit of technical glitches always are there, even when we do the webinars, there are sometimes we are unable to share the presentations. So apart from that, we have learnt a lot, and here the sisters are in huge number, the paramedicals and the students, medical students, teachers, doctors, all are assembled here at NMCH auditorium in the OT and at Moria. I'm very happy to see such a huge crowd. So to give the formal welcome address, may I request Dr. Vinita Singh, Chairperson Workshop Committee, to kindly come up, Madam.
Very good afternoon. Really, I'm feeling so happy to see hall full, whether it is Maurya, Ashoka, or this is auditorium. So at the very outset, I would
सिंदूर लाल चढ़ायो अच्छा गजमुख को, रोंदिल लाल विराजे सिक गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को, जय देव जय देव। जय जय जी गणराज विद्या संदाता, कन्या कुमारो दर्शन मेरा मन रमता, जय देव जय देव। भाव भगति से कोई शरणागत आवे, संतति संपत्ति सब ही भरपूर पावे। ऐसे तुम महाराज को अति भावे, गोता भी नंदन नित दिन गुण गावे, जय देव जय देव। जय जय जी गणराज विद्या सुराता, कन्या कुमारो दर्शन मेरा मन रमता, जय देव जय देव।
Thank you very much. Now I invite Dr. Supriya for vote of thanks.
Sorry. Before that, our chief guest, Dr. Shanti Roy Madam, Pradman Shri Dr. Shanti Roy Madam, who is teacher of teachers and the inaugurator of today's program, she will kindly bless, she has already blessed the webinar, this conference, this live workshop with her, even though she has shown the live internal iliac artery ligation, and then she has blessed by inaugurating this whole live workshop. And madam, I request you kindly to bless, give us a few words of blessings. Madam, yeah, madam will be. So we are really blessed to have, madam, यहाँ आ जाइए. उनको पूछे चलाओ. Yes, so over to madam.
Thank you very much, Supriya, for inviting me to bless you and the inauguration committee, especially Dr. Vinita Singh. I am very much thankful to you for inviting me to be the chief guest of today's function. As you all know, now lady clinicians, they are refusing to go into obstetrics because PPH is a nightmare for everybody.
Dr. Mahesh Gupta, sir. Come up and do the honors. So it's really heartening to see that people, those paramedics and these sisters, they take keen interest and a very disciplined scenario seen here at NMCH, very well organized. And so it was wonderful. Thank you very much.
Now I would like to invite Dr. Supriya Jaiswal. She is chairperson, Adolescent Committee Foxy and Vice President, Fox Foxy. So now Dr. Supriya, she is invited for vote of thanks. Please come, Supriya.
Yes, already everything was done very well. So first of all, I thank all the seniors and juniors members who have taken out their time on this day to reach in time right from the morning 8 o'clock. People are on foot. Even the poster presentation people, the presenters, all were there. So the houseful is really heartening to see here at NMCH. So I really thank all the people who took keen interest, and then the organizing team, Dr. Mahesh Gupta, sir, the operating faculty, Dr. Deepak Desai, Padma Shri, Dr. Shanti Roy Madam, Dr. Alka Pandey Madam, Dr. Nalini Mishra, Dr. Mahesh Gupta, sir, again he had another case he is going to show, and Dr. Shashi Lata Kabra, who have taken pains to come for months together. It was planned and things have been in order today. So I thank everyone and I thank Chairperson the workshop committee, Dr. Vinita Singh. She has organized it very well along with myself and Dr. Veena Sinha. I thank the President and Secretary, the organizing chairperson, Dr. Meena Saman, Dr. Amita Sinha, Secretary of Patna OBGY Society and Organizing Secretary. Then I also thank the national faculties. Dr. Jaideep thanks sir, the President Foxy, at present Dr. Madhuri Patel Madam, Dr. Bhaskar Pal sir, the convener of this program, and the national advisor is Dr. Mahesh Gupta sir. And lots of thanks to the whole department of NMCH, starting from all the faculties, Dr. Alka Sinha Madam, who is the superintendent of NMCH, Dr. Usha Kumari, principal NMCH, who has really made
So that was the grand inauguration of this workshop, and we will quickly move over to our next session, and that is by Dr. Shashi Lata Kabra, an internal iliac ligation. And for that, may I invite, we have past presidents of Patna Obs and Gynae Society, Dr. Kumkum Sinha ma'am, and Dr. Neelam ma'am. And along with that, we have our moderator, Dr. Usha Sharma ma'am. Dr. Usha Sharma ma'am, you are moderator in this workshop. Please come over the dais. Yes. So we have the blessings of all our past presidents of Patna Obs and Gynae Society, and it really means a lot to us. We have been working under their guidance. So again invite Dr. Abharani Sinha ma'am, our co-convener, to come over the dais.
Good evening. Good. हाँ अभी हम ले लिए. Good afternoon, everybody, and thank you so much for giving us this opportunity to chair this important session. It is my proud privilege to introduce Dr. Shashi Lata Kabra Maheshwari, Madam. She has been awarded IMA Appreciation Award, recipient of Wonder Foxy Award 2019, APJ Abdul Kalam Appreciation Award, IMA WDW Karamveer Award, Champions Award Obstetric Critical Care 2021. Again, APG Abdul Kalam Excellence Award in DGF 2022, DDU Hospital Best Doctor Award. I mean, she has so many awards. And latest perhaps is organized 82 workshops on PPH all over India. That's very commendable thing. And she's associate of prestigious RCOG and patient right of teaching model on IIAL. So she will be speaking a life-saving procedure for intractable PPS, that is internal iliac artery ligation. And Madam, floor is yours. Please start.
Good afternoon. Thank you so much, ma'am, for such a kind introduction. And first of all, my heartfelt thanks to Patna OBG Society, Dr. Meena Saman, Dr. Amita Sinha, and National Convener Foxy, Dr. Bhaskar Pal, and whole Foxy team for having me here. So internal iliac artery is a life-saving procedure. And in order to save life, we have to learn this procedure. Move kaise karega? So we have anatomy classes in first year. You can see here. The biggest vessel in our body at the level of L4 and L5, it divides into two common iliac arteries. And each common iliac artery in succession divides into external iliac artery and internal iliac artery. The lumen of the external iliac artery is bigger and that of internal iliac artery is little smaller. And this level is at L4, LL5. Then this insert had been shown here. Here you see this is one-sided common iliac artery. This is lateral side, this is medial side. This common iliac artery divides into external iliac and internal iliac. An internal iliac artery just after its origin gives the posterior branch. And we have to ligate this. So the posterior division, as sir had said, are parietal branches, and we are concerned with the anterior division. And the most important arterial supply is uterine artery. Uterine artery bleeds 800 ml per minute during postpartum hemorrhage. So we have to control the bleeding in 7 to 10 minutes. So this is the collateral circulation. Now coming to the relations, anteriorly there is peritoneum. We call it retroperitoneum. जब हमको internal iliac करनी है, तब हमको retroperitoneum खोलना पड़ेगा. Then medially we have ureter. Gynecologists are always afraid of ureter. भाई ureter से नहीं डरिए. Ureter lies in the medial flap, such a goody structure कि भाई मैं तो medial flap में हूँ. You do whatever you want on lateral side. Then inferomedial, we have internal iliac vein. Laterally we have psoas major muscle and internal obturator muscle. And inferolateral we have obturator nerve. Now, this is one picture of after dissection. This is external iliac, this is internal iliac. I'll show you my own video. So how does it work? Bilateral internal iliac artery results in 85% reduction in pulse pressure and 50% reduction of blood flow. So basically it converts an arterial blood flow into a venous flow, and thus coagulation is facilitated. Bleeding is reduced and the life is saved. Technically it is difficult initially, but one picks up it very easily. तो मतलब आज का मैसेज ये है कि हम सबको इंटरनल iliac artery ligation सीख के जाना है. So latest Pphcon guideline 2022, it recommends internal iliac artery ligation as one of the options to rapidly control postpartum hemorrhage for management of postpartum hemorrhage when medical non-surgical approaches and compression sutures fail. Pphcon also recommends that all obstetricians familiarize themselves with the internal iliac artery location and with the technique of its ligation. अब एक दिन में तो सीख नहीं जाएंगे internal iliac artery. हम कोशिश करते हैं आज हम location सीखें, anatomy सीखें, technique सीखें और धीरे-धीरे we will go on. So there are two approaches, with uterus, without uterus. If hysterectomy is done, we can perform internal iliac artery ligation. If uterus is there, we can also perform internal iliac artery ligation. Those situations हमारे पास we have uterus present or not, and the approaches are two again, anterior approach and posterior approach. When we bring the uterus forward and open the posterior peritoneum, then it is called posterior approach near the pouch of Douglas laterally. And when we make a nick through the round ligament, then it is called anterior approach. These two are my best companions for performing internal iliac artery ligation. This is mixture forceps. In the evening at 5 to 7 p.m. in my workstation, I will show you this mixture forceps. And yeah, what is this? This is a thread number 1 silk, which is just doubled. And it really causes magic. So this is my video. When I used to be called in my labor room, where we have 10,000 deliveries per annum. Then every time when I used to do internal iliac artery ligation, new batches of residents used to come and nobody knows what to do. They don't even know the anatomy. So that struck my mind and I made a model for this, at least to show them what actually internal iliac artery ligation is and what the anatomy is. Internal iliac artery is a retroperitoneal structure, and in order to ligate the internal iliac artery, we have to work in the depth of the abdomen. So that's why I have given to work in the depth of the pelvis. Now, thinking this is the abdomen and abdomen opened, now we are inside the abdomen. So in order to ligate the anterior division of internal iliac artery, we have to open the retroperitoneum. So after pushing the uterus anteriorly, we look at the retroperitoneum and we have to open the retroperitoneum. Now there are two methods of opening the retroperitoneum. One method is make a nick on the peritoneum 2 cm below and 2 cm lateral to the sacral promontory and enlarge that nick and open the peritoneum. So we will reach the bifurcation of the great vessels, bifurcation of the common iliac artery. And second method is, which is more commonly used by me, is make a nick in the middle of the round ligament in the peritoneum, and then from that nick proceed up to the base of the infundibulopelvic ligament, gently cutting the peritoneum about 7 to 10 centimeter and then open that retroperitoneum. This can be opened with the uterus being there and even after the uterus is removed. And how to open the retroperitoneum? Once you have opened the retroperitoneum, then there will be two flaps, one medial and one lateral. This is the medial side and this is the lateral side, and medial flap always has ureter. So when you do internal iliac artery ligation, never get afraid of ureter because ureter always remains in the medial flap. And this is the lateral flap. And how to see the structures below the retroperitoneum? You keep all the instruments aside, and just after opening the retroperitoneum, there is loose areolar tissue, so you just separate it with your finger movement without taking any instrument. And then you will see the bifurcation of the common iliac artery.
This is inverted
So,
Y.
in order to ligate the internal iliac artery ligation, the first important step is open the retroperitoneum in the vicinity of the great vessels. Second thing is recognize the bifurcation. Unless you recognize this bifurcation, we can't proceed anywhere. This looks like an inverted V, inverted Y. This is common iliac artery. This is showing only one side of the great vessels. This is lateral side. This is medial side. This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and the internal iliac artery just after its origin, this iliac artery just after its origin gives origin to the posterior division, and the anterior division is continued. We have to ligate the anterior division of the internal iliac artery in order to reduce bleeding from postpartum hemorrhage. So we have recognized the bifurcation. Now we have to recognize which one is internal iliac artery. External iliac artery is a lateral structure and internal iliac artery is a medial structure. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go because femoral artery is a continuation of the external iliac artery. And when we release this pressure, the femoral pulse will come. So this is how we recognize external iliac artery. When we apply the same pressure on the internal iliac artery, there will be no change in the femoral artery pulsation. So this is how internal iliac artery is confirmed. So we have recognized internal iliac artery. Now our next thing we have to do is we have to recognize the site where the artery needs to be ligated. Now how to identify the anterior division? Normally in the pool of blood, this posterior division is not seen. But you see here that this posterior division is given very soon after the origin of the internal iliac artery. And if we measure the distance from here, then see from the bifurcation, within 3 centimeter, this branch of posterior division is given out. So we can safely ligate this anterior division of the internal iliac artery 3 centimeter below the bifurcation. So now it is clear. In live surgery, how will we identify this? See, if I place my thumb here, then the length of my folded thumb is around 3 centimeter. So I'll just put my thumb here at the beginning of the bifurcation and around 3 centimeter. This is the place where I can recognize the internal iliac artery needs to be ligated. So now I have identified the site also. Now next is how to do the dissection. Before that, I'll show you this instrument. This is right angle forceps, also called mixture forceps. It is bent at 90 degree and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. So how to proceed for dissection? See, there is a sheath-like structure. I have used my kitchen cling film to give the appearance of the sheath. It covers all the vascular bundles. Like both this is internal iliac vein, this is internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. This is my proposed site of ligation.
This movement is parallel to the vessel.
So I am separating it like this. Now I have separated this. Now next step is I have to pass a silk thread. I use number 1 silk below the artery. And one very important thing is that when we have to pass the right angle forces from lateral to medial on both the sides.
Lateral
If
to
I
medial
pass
is the
from
what?
medial to lateral, then again there are chances of injuring the internal iliac vein. So this movement will always be from lateral to medial. And one more important thing, the wall of the artery is thick and the wall of the vessel is very thin. So when I pass this, then I will graze through the lower surface of the artery. My movement will be against the artery, not towards the vein, because
Will apply more
if
pressure
I make
on
it
the
like
arterial
this,
side.
then I will puncture the vein. So these are 2-3 precautions and important points. Now I will pass this right angle forces at the proposed site of ligation from lateral to medial, and my assistant will show me a silk thread. Look at the thread. This is a silk thread. Number
See just
one.
how I make the silk.
I made it double, making a loop like this. And my assistant will give this to me. I have already made a place here for ligation, passing the right angle forces from lateral
Now
to
you
medial.
can see loop is already there, ready.
Gently I will open it, and I will get
just
hold of the
gently pull
loop, and just gently I will come out like this.
Your instrument is grazing through
This
the wall,
movement is very,
grazing
very
through the wall of the artery.
Now next step is I will cut this and make 2 threads.
So with one instrument movement, I made 2 threads. Can you appreciate this?
Now my assistant will help me in identifying the threads.
So this decreases the chances of injury to the vessels.
Yeah, I've done it. This is one thread, and this is another thread. See, this is plain and this is another thread. Now I have to apply 2 ligatures 0.5 to 1 mm apart. So look at the technique of applying ligature.
We apply 2
Taken
ligatures.
hold
Now
of
look
one
at the
ligature.
technique.
I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is
2
second
turns
turn.
in the
And
first
I have
knot.
tied it here. Then very gently I applied the second throw,
Then ligate.
and again very gently I applied the third throw. Without pulling the artery, I myself cut this.
Never pull the artery.
Just without giving
Go
any
up to
pull
the
on the
artery.
suture, I'll cut this. Now taking the second thread, this is 0.5 to 1 mm away. I made 1 turn and 2 turn. This is a square knot, and I applied the suture here.
This is how.
Again, I am
Yes,
not pulling the
0.5
artery. I am
centimeter
going
apart.
up to the superior surface of the artery.
So the very important message is that you have to pass, as Dr. Bhaskar Pal has also said, pass the right angle forceps from lateral to medial. Lateral to medial, lateral to medial, and lateral to medial. Because if we go reverse, then we will injure the external iliac vein. So now this is a real case. Maybe I might be taking more than 2 minutes more, but I have to share this. This was a 26-year-old primary gravida with full-term pregnancy, booked initially in one facility. Then she had ANC at one Anganwadi center. Then she had labor pain on 23rd November 2022 and rushed to 3rd hospital at night, went into obstructed labor, taken to another 4th private hospital, undergone emergency cesarean section for second stage arrest and the spinal anesthesia at 8 a.m. And she had an episode of postpartum hemorrhage at 10:15 a.m. and which was managed medically. So delivery at 8 a.m. and postpartum hemorrhage at 10:15 a.m. they noticed. Then she had again second episode of postpartum hemorrhage at 12:30 p.m. and she developed shock. So they took her to OT, and under saddle block anesthesia, the obstetrician did left lateral cervical tear repair and a posterior vault repair. And she was given 1 unit of PRBCs and 4 units of, further 4 units of PRBC, 4 FFP and platelets. Then after 11 hours at 7:15 p.m., the patient went into shock again. And she was resuscitated and referred to me with 5th unit of PRBC on flow. So when we received the patient, her pulse was 146, BP is looking normal, 104/60. But when you see in depth, her shock index was more than 146/104. And her uterus was soft, per abdomen was soft and uterus contracted, per vagina there was significant bleeding. I took no time in making the decision of opening the abdomen in this case. So I opened the abdomen with the right paramedian incision, and there was a huge broad ligament hematoma on the posterior surface extending from the fundus to the colpos.
So we performed the hysterectomy in that case. And now after hysterectomy, there was slight oozing here and there, so we performed an internal iliac artery ligation. This is a real case, and the video is unedited. From incision to the procedure, less than around 6 minutes. Just watch this. So here, I will go through round ligament pedicle. Hysterectomy done. This is round ligament pedicle. Can you appreciate this? Please, all lights off. This is the peritoneum from the round ligament pedicle, which I am cutting and moving laterally, parallel to the infundibulopelvic ligament towards the lateral pelvic wall. Please put off all the lights. So can you appreciate this? The thin peritoneum I am cutting without injuring the structures which are lying below. Now I've kept all the instruments, and with my 2 fingers, I am opening the loose areolar tissue. At this moment, you should not have any instrument in your hand. This is the inverted Y which I am going to see. Because of lights, this resolution is not seeing that good.
No, it is
visible. Okay. So this is common iliac, this is external iliac, this is internal iliac. This is inverted Y, you can appreciate, I think. External iliac, internal iliac on internal side, and this is inverted Y. जब तक आप inverted Y को नहीं देखते, तब तक कुछ नहीं करोगे आगे. You have to make the inverted Y prominent. Now you see how I am doing it. Can you see it now? Please tell me whether you can see or not.
Yes.
Yes. This is, now I am pressing the external iliac artery and seeing the femoral pulse. It goes, and on lifting the pressure, it comes. Then again I am pressing the internal iliac artery, and there is no change in femoral pulse. So it is doubly confirmed. Now I know that this is internal iliac artery, and I know that I have to go 3 centimeters below. Only at that place, I will start ligation. So the movement of my mixture forces parallel to the vessel, because the internal iliac vein and artery, they both are enclosed in a sheath. So then you have to cut the sheath. You have to make a space between the artery and the vein. So this is what I am doing. You just see. The assistant is beautifully cutting it. Again. So I am not doing dissection along the whole length of the structure, only at the proposed site of ligation, which is 3 to 4 centimeters below the bifurcation. आप जितना लंबा उसको डिसेक्ट करो, उतनी जगह आपकी इंजरी की चांस बढ़ जाएगी. Now this is going lateral to medial. And or your instrument will graze through the artery. Artery जितनी मोटी होती है, जितनी बड़ी होती है, उतनी मोटी होती है. Vein जितनी बड़ी होती है, उतनी thin होती है. Now the loop has to be kept already ready. So the loop has been taken. Purpose of loop क्या है कि with one movement of this instrument you can make 2 threads. 2 movement instrument के करोगे तो there will be double chance of injury. So now it has been cut.
Madam.
Yeah. Right. Yeah, yes, ma'am. Yes. Definitely. So very gently you have to separate the threads, that which one is continued with which one. This is an unedited video that in grave emergencies, don't get panic and do this. So now I am applying the first ligature, 2 turns in the first knot and next 2 knots in reverse direction. Don't pull the artery. Bend your back and bow your head. Just put the knot on the surface of the artery. You are saluting the artery. It is one of the biggest vessels of the body. तो आर्टरी को सैल्यूट कर दीजिए. Now without pulling the artery, you cut it. Can you remove this? Okay. Yes. So without pulling the artery, you have cut it. Can you see the first ligature in place here? Now second ligature is being, it is 0.5 to 1 centimeter away from the first one. It doesn't matter which one you make first and which one you make second. And you have seen here that posterior division is usually not seen in a pool of blood. So posterior division को देखने के लिए मत कोशिश कीजिए. Just go 3 to 4 centimeter below the bifurcation of the common iliac artery. So the second, you just see a bulge, beautiful bulge between the two sutures. Can you appreciate this? Please tell me. So the on internal iliac artery, we apply two sutures. We never cut it, remember. We never cut it. It is just like this. Only 1 minute, only 1 minute. So now you see internal iliac artery with two ligatures, external iliac artery, and this is common iliac artery. Thank you. Ma'am, yeah. Yes. Ma'am, एक slide मेरे को और बोलने दीजिएगा.
हाँ, जरूर जरूर.
So I have performed more than 110 internal iliac artery ligations in last 22 years in Dindal Upadhyay Hospital, and these are my own tips, not copied from any of the books. Open retroperitoneum from noun ligament to infundibular pelvic ligament, that is the easiest method. And for posterior, this is for anterior approach. For posterior approach, you make a nick on the peritoneum 2 centimeter below and 2 centimeter lateral to the circle promontory, lift the peritoneum and cut it. Then once you open the peritoneum, do only finger dissection. Don't use any instrument that time, otherwise instrument will prick and injure the vessel. Then locate the bifurcation, that is inverted Y and inverted Y. Then recognize internal iliac artery as a medial structure, which does not cause any change in the femoral pulse. External iliac artery does cause change in femoral pulse. Then movement of your right angle or mixture forceps always from lateral to medial, never the reverse. Then careful not tying in the cavity. आप artery के सामने झुक जाओ, उसको उठाओ मत. Then two ligatures 0.5 to 1 centimeter apart. Or one very important point, always do bilateral. लोग कहते हैं कि मैंने तो एक करा, एक करेंगे तो effect भी आधा मिलेगा. Always do bilateral. Chances of free laparotomy and morbidity increases if you do single internal iliac artery ligation. This is from literature. And for beginners, first start opening the retroperitoneum in gynecological hysterectomy and take help from your surgeon friends. So this is my journey. Initially opening the retroperitoneum in gynae hysterectomy, then I observed 2 to 3 cases, then in obs case assisted 4 to 5 cases, then performed 3 to 4 cases under supervision of a surgeon friend, and then in obstetrics whenever it was required. It is preferable to take the assistance of senior colleague or surgeon friend. This is my patent model which I have got for that instrument. Thank you so much. Yes, ma'am.
Your practical points were very, very good. Especially one point that you haven't referred in your summary, that was the direction of the mixture when you are dissecting the fascia. Only dissect the fascia in the area where you are going to ligate. Don't be overzealous and don't try to dissect from above to downwards.
Exactly.
And the second point, that is the direction of the mixture. Don't poke it down and put it parallel. I think these two practical points were really golden words. And as practitioners, we know how important this is. And for juniors, the other point that you said, always see the bifurcation.
Yes.
Don't ligate anything without seeing the bifurcation. Palpate the femoral pulse and don't try to see the posterior branch. If you are just tying it 3 to 4 centimeter below, the posterior branch is already been given.
Yes.
It is visible. Okay.
देखें कहाँ से ब्लीड कर रहा है. थोड़ा सा और इसको थोड़ा सा. इसको ले लीजिए.
सबको छोड़ा जाए न माइक उनको लगा दो शांति दी मैडम को लगाओ हम देखे ध्यान नहीं दिए मैडम को माइक
So we are having a very good video
Mic,
over
mic,
there,
huh.
but we are
We
not
are in.
able to get any audios. May someone describe the procedure being done?
Hello. Now case is ready for internal iliac artery ligation, and operation will be performed by Dr. Padmasri Dr.
Addressed. Thank you so much. Thank you, it was a pleasure hearing you and seeing your video.
Tooth forceps.
I just wanted to thank you, Shashi, as usual. Great talk. Shashi has a, it's a very wonderful,
Hello.
wonderful teacher. Just
अब
give me
आपको
2
ऐसे
minutes. We'll get
spread
it.
करना है, दोनों
I
हाथ
just
से.
want to say that
Yes.
today you and
Hello.
Shanti Rai
Hello.
madam both showed us the lateral approach. But there is also a posterior approach where you do not have to go through the round ligament. And that's something which we do in laparoscopy and very easy to do in
See,
obstetrics.
I'm using this.
You just
I'm
take
not
the
using
uterus
this.
out, flip it forwards, identify the psoas muscle and start from there. So go
Okay.
beyond your infundibulopelvic ligament. So
इसमें एक हाथ
actually
से
we
ऐसे
feel
करो.
that that is an easier approach in obstetrics.
So,
Dr. Shashi, thank you very much. And you have really highlighted the practical points. Your dissection was beautiful. One question.
So what
How
happened?
long
You will
did
not
you
find
take
any
to do
bleeding.
it?
Yes, ma'am?
How long did you take to do the case you showed? How long did you take to do the internal
Ma'am, it
iliac
was 7 minutes from after making incision through the round ligament.
Thank you.
It is an unedited video, ma'am.
Yes.
Thank you
Thank
very
you.
much, ma'am, because the case has been started. Dr. Shashi, ma'am, may I request the chairpersons, Dr. Usha Sharma, ma'am, Dr. Abha Rani Sinha, ma'am, Dr. Kumkum Sinha, and Dr. Neelam, ma'am, to kindly come over the dais and
Recording in progress.
I request everyone to come at 1:45 p.m. for inauguration of scientific session. We will start
देखा?
exactly
Culture
at
structure है.
2
ये
p.m.
रहता
our
है.
scientific session.
देखा मैंने हटाया. मैं बताऊंगा. posterior
So
से internal iliac कैसे होता है? Yes. Hello. Start my.
I will not take a lot of time because we want to be on time, and Mr. Raj is here. He will push me off the stage. So with those welcoming words, I once again welcome you all to the sign. I'm sure it's going to be a marvelous one. We have such learned faculty here with us who are going to make our day very fruitful. Thank you.
So may I now request Dr. Usha Didwania, ma'am, Chairperson Scientific Committee, to say a few words.
Good afternoon to all of you. I am privileged to welcome you all on this occasion of Pphcon PPH Conclave, which is being held for 2 days here in Patna. You all had a very rich, very informative workshop in the morning, and now from now onward till tomorrow 5 p.m. you will have a very rich scientific lectures bonanza. And in this evening, there is a very good hands-on training also. And you will, I'm happy to announce that we had expected around 400 delegates to be registered, but it is now more than 450, around 475 registrations has been done. And I am really indebted from the organizing committee. On behalf of our organizing committee, I really welcome to our national experts who have come here, who have taken pains to come over here and enriching our knowledge and giving us many practical tips for this PPH, and which is a very dreaded condition. We all are feared to face such situations. So I again welcome to all of you from core of my heart. Thank you.
Okay, thank you very much, ma'am. May we have a few words from Dr. Bhaskar Pal, sir, our national convener?
Good afternoon. Welcome everyone. I will speak in the evening at the inauguration. So I'll say what I would rather not say there. I think I've been coming to Patna Society since possibly 2004. And Patna Society has a different, in a different era at that point of time. I have seen Manjudi in her heydays, etc. And suddenly Patna Society changed after the AICOG. And I remember when Meena was the secretary of Patna Society, Bashov and I came for the Pphcon. And for the first time, we stared at Meena made everybody dance to her tune on the stage. So, and I have seen that Meena ki isharo se sab log nachte hai idhar. But she's very tough also. She actually sent us a message to us saying that there are 9 people on the dais, we have 1 hour, don't speak more than 2 to 3 minutes. So I guess this is what that if you have to say anything extra, please speak here. But I think great job done. When I initially brought this conference to Patna, I would have been happy with 300, to be very honest. And I think when Meena told me day before yesterday that we are heading towards 500, I think it's a brilliant job, meticulous planning, excellent content by Mahesh, perfect execution by Meena, Amita and team, careful planning of scientific program by Ushadi, and I think this morning's crowd actually showed us that this is a great success. Handpicked faculty, we can already say there's a hugely successful conference, and India's got a lot of innovative contribution in the world of PPH. So please enjoy, and I think this is something we are planning to do one more by the end of this year, and this is something which will take it all around the country and do maybe 2 to 3 every year. Thank you, on the similar model.
Thank you very much, sir. So definitely we have arranged everything, live operative workshop, video sessions, hands-on training, and many lectures. So this is time for auspicious inauguration of this scientific session. And may I request Hari ji to play a divine blessing song. And may I request our chief guest, Dr. Manju Geeta Mishra ma'am and Dr. Pramila Modi ma'am to kindly lead and light the inaugural lamp. And all the dignitaries on the dais, Dr. Abha Rani Sinha ma'am, please come on the dais. She is co-convener of this conference. May I request Dr. Monica and Dr. Mini to kindly bring the help in lighting of the lamp. Monica, please come. Monica has also worked very hard along, and Dr. Mini Anand, they have been, yeah, please come. Please help in lighting of the lamp.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
Let's have one round of applause. It's a perfect inaugural time for us to get started with these scientific programs.
So just a few words of thanks from Dr. Amita Sinha, the organizing secretary, who we can just see running and smiling always.
Yeah. Thank you all.
only this word is not enough to thank you all, and thank you, my team. Thank you so much. Enjoy. I don't want to come between you and scientific session. Thank you.
So that's all for the inauguration. Now, Raz, our event manager, will take over with the time management.
Yes.
And our coordinators, first coordinator, Dr. Richa Jha, please.
Yes. All right, we are 2:07. We'll get started. Dr. Richa is there to start the first session for the scientific program.
A very good afternoon to all the respected teachers and my seniors present in the hall today. On behalf of POGS, Patna Ops and Gynae Society, I welcome you all to the scientific session of Pphcon Conclave 2024. And for the next session, I invite the esteemed chairpersons on the dais, Dr. Usha Sharma ma'am. She is the immediate past president ISOPAP 2020 and consultant obstetrician and gynecologist at Patna SK Memorial Hospital and AK Memorial Nursing Home. Dr. Vibha Chaudhary ma'am. She is the senior consultant obstetrician and gynecologist and director at Tapaswi Multi-Speciality Hospital and Baby Boon IVF Center, Bhagalpur, Bihar, and also the president of Bhagalpur Ops and Gynae Society. Dr. Ranjana Khanna ma'am. She's National Vice President, she was the National Vice President Pphcon 2017 and founder president of ISOPAB at Prayagraj 21 to 25 and as the senior consultant and director at Ranjana Hospital, Prayagraj. And Saroj Singh ma'am, who's a senior consultant practicing in Patna. I welcome you all ma'am and I request the chairpersons to kindly invite our first speaker, Dr. Haresh Doshi sir.
Okay. Okay. A very good afternoon. After the wonderful lunch, I think all of us are prepared to welcome Dr. Harish Doshi and his wonderful talks. I am really impressed by his oratory skills. He is professor and HOD of OB/GYN, GCS Medical College, Ahmedabad, Gujarat. Lot of publications to his credit, and of course he is a national and international faculty. President AOGS, that is Ahmedabad Society 203, and President SOGOG 2004, organizing secretary for AICOG 2000 Pphcon Conference, chairperson Practical Obstetric Committee. And I request you, Dr. Harish Doshi, and I look forward, I think everybody looks forward to hearing your talk.
Thank you, madam, for making it short. But you said after delicious lunch, the next sentence in my mind was, we are ready to sleep. I will not allow you to sleep. Well, honorable chairpersons, senior faculties and obstetricians in the crowd, I saw so many here and so many down there of the dais. I just really salute all of you, senior madams, I mean, Nari Sakti Vandan. Well, I'm extremely thankful to Pphcon office bearers, Dr. Meena, organizing chairperson, Dr. Amita, secretary, and the whole team of this conclave for inviting me to deliver this guest lecture. Mr. Raj, I am the opening batsman. In IPL, there are 20 overs. So please give me 15 complete minutes. Okay?
Okay.
Well, this is the seniors have read this book, Ian Donald, in a 22nd chapter, postpartum hemorrhage. It starts with this sentence, third stage of labor. This is indeed the unforgiving stage of labor, and in it lies the more unheralded treachery than in both the stages of labor combined. The normal case can, within a minute, become abnormal, and successful delivery can run into a disaster. Great Ian Donald, right? I suggest the juniors to read this original book, textbook of Practical Obstetrical Problem, Ian Donald. I was initially given this topic and then changed to third stage of labor. So I'll be, because of short of time, only concentrating on AMTSL. The most effective strategy to prevent PPH is active management of third stage of labor. AMTSL is associated with nearly more than 60% reduction in PPH occurrence. Not only that, it decreases not only the incidence, or also the severity of PPH if it occurs. Expectant management of third stage labor, we seniors used to practice, has become the thing of past. It is no more existent. Fine. More than a decade back, WHO came with clear-cut criteria for AMTSL. The use of uterotonics for the prevention of PPH during the third stage of labor is recommended for all births, all vaginal deliveries, all cesarean sections. Oxytocin was the recommended drug. Delayed clot clamping for the baby benefit and other benefits. At least 1 minute, 1 to 3 minutes you should clamp the cot, not immediately. Controlled contraction is recommended naturally for vaginal birth. Scale birth attendant is not there, it is not to be done, but it is not our place, we are the doctors. Postpartum abdominal uterine tone assessment, continue to check every 15 minutes after third stage is over, 4 stage plus 1 hour. If there is uterine atony, perform fundal massage. Oxytocin quality and supply, ensure a continuous supply of high quality oxytocin, cold chain. After 6 years, WHO changed somewhat its criteria, recommended other uterotonics for AMTSL, that is carbetocin, now coming up very fast, ergometrin, methylergometrin, oxytocin per ergometrin, oral misoprostol. In 2020, WHO further revised this guideline that now not IM oxytocin, but slow intravenous oxytocin, 10 units, is the preference. It is better than intramuscular. FIGO, International Confederation of the Midwives, in 2022, and then our Pphcon and AOFOG recently all approved this recommendation. Coming to this, Cochrane 5 years back did this a huge meta-analysis, right? 196 trials, more than 135,000 women, and concluded that carbetocin may be more effective than oxytocin for some outcomes of prevention of PPH, right? Without an increase in side effects. FIGO, now this is new. FIGO in 2022 and American Journal of Obstetrics and Gynecology, Maternal Fetal Medicine, 2023, they suggested not a single drug like WHO oxytocin, combination of drug, ergometrin plus oxytocin, misoprostol plus oxytocin, carboprostol plus oxytocin, more effective uterotonic strategies than for prevention of PPH more than 500 ml compared with oxytocin alone. And believe me, ladies and gentlemen, we are practicing this only. We usually give more than one drug, right? So that is there now come with the evidence. Uterine massage is not recommended if prophylactic oxytocin is given. WHO and FIGO both suggested this. We have given oxytocin for AMTSL, so no need for massage. Again, Ian Donald. Anyone who cannot be taught to keep his hand on the fundus, absolutely still should be strongly advised not to take up obstetrics, right? Because what happens with fiddling and kneading of the uterus, there is an incomplete separation of the placenta and there is a more bleeding rather than less bleeding. Ladies and gentlemen, PPH is the commonest killer, we all know. Not only that, it is also the fastest killer. So we require what? A foolproof prevention, a very good, strong drug. We require, right? Babu Rao has come, right? मेरे को बिल्कुल रिस्क नहीं लेने का हेरा फेरी. So wonder the carbetocin has come, is a long-acting, enhanced stability, heat stable, higher affinity for oxytocin effector, a new arrow in our quiver. This was started 2.5 years back, first for AMTSL in Karnataka, Belgavi, right? Since then, we are routinely using in our institute. Mode of action, mode of administration, 100 microgram IM or slow IV, no need to give like oxytocin drip and all that continuous, single dose. Administered as soon as possible after the delivery of the placenta, preferably before the delivery of the, as soon as after the baby and preferably below the delivery of placenta. Firm contraction is achieved in 2 minutes. This is my patient, cesarean section. You can see it becomes stony hard. Uterus becomes stony hard. Head-to-head comparison with the oxytocin. The all oxytocin on right side, you can see the font's color is red. Stability is more, heat stable, no? Carbetocin, like misoprostol, no need to keep in freeze. Half-life more, duration action more, uterine contraction more, frequency, more amplitude. Less hypotension, less antidiuretic effect. We do cesarean section in the morning, we give pitocin, anesthetists give pitocin drip. By the evening, urine output is 100 ml. You are worried, right? But it is there because of oxytocin. Carbetocin does not happen. PPH more than 500 ml, it is superior to oxytocin. Only thing cost is more, but that I put a yellow star because the government of India and Faring, and they are trying to bring down the cost. Champion trial, WHO, right? Again, 30,000 women, right? 23 sites and 10 countries demonstrated non-inferiority of carbetocin versus oxytocin for prevention of the blood loss more than 500 ml. Heat-stable carbetocin does not require refrigeration and therefore eliminates the cost associated with storage and cold chain transport in oxytocin. So WHO included this drug in 2019 in the model list of essential medicine. See, Canada has come, they have come with now the first line of drug. Everywhere oxytocin stop. For cesarean section, they give only carbetocin for AMTSL, and for vaginal delivery with one risk factor, they recommend and practice and do the whole country carbetocin. So ladies and gentlemen, all our parent organization, our mother, our father, our grandmother, our grandfather, our uncles, all recommend carbetocin. Okay, so if you are not still convinced, I have brought, right, Amitabh Bachchan for you. Pehle istemal kare, fir viswas kare. If old is gold, the new is diamond. Okay, so I was told that you have to cover the third stage, all the other things, because other big complication, inversion and all, like embryonic fluid embolism and all that, not. PPH is the whole conference. So couple of slides with retained, and I will end. Retained placenta is increasing in modern times. I will not say the reasons why it is increasing. If there is no much bleeding, after 30 minutes, you can still wait for more 30 minutes, right? It is not that you immediately enter. But if there is excessive bleeding in that 30 minutes also, you have to interfere. This 20 to 40 in oxytocin, we have done the dissertation also. Results are okay, not very well, right, proved, but you can wait till the anesthetist comes, you can do. Some tips for MRP. Under anesthesia, introduce the full hand and the forearm also high in the uterus. Take care to minimize the profile of your hand, cone shape. This is important. Second point, going between the membranes and the uterine wall, which is not that easy, but you put a speculum because baby has come to the perforation, rupture of membranes. Baby was delivered. That membrane you can take with a saw boulder and go behind the membranes inside the uterine wall. You can easily reach the edge of the placenta and easy to separate the placenta. Nowadays, this is coming up. Intrapartum USG, first stage of labor, second stage of labor, even if you have taken the patient in OT, ultrasonography helps many times, right? Ultrasonography intrapartum. Exact site of attachment and also differentiate from simply adherent or past disorder. This is my photo. This is just showing outside the uterus, not doing MRP, but not this much up to umbilicus. You have to go up to the fundus. His vagina is after delivery so stretchable. When you pass your hand for MRP, the uterus goes from liver to spleen. Right, ladies and gentlemen, so have that, right, important thing that sweeping movement from side to side, up and down, clogging is to be avoided because it will tear the placenta. This is important. Other hand place abdominally, steady the fundus, then only you can do the procedure, right, and allows counter pressure to be exerted. Gain experience at cesarean section. Otherwise, for few cases, otherwise routinely we don't do. Okay. Better to remove in one attempt. Repeated insertion of hand naturally leads to infection, but it is to be said. It is difficult in practice. 2-3 बार तो हाथ डालना ही पड़ता है. So that happens. Before the hand is removed, oxytocin is started, right? I mean, that is to check the uterine contraction. Examine the placenta naturally for its completeness when it is delivered. So, ladies and gentlemen, key points. AMTSL should be universally practiced in all deliveries cesarean section. Oxytocin 10 units IV slowly is the latest recommendation. Recently, carbetocin IM IV is increasingly used as first line of drug. Combination of drugs nowadays are more helpful in prevention. New concept is coming up. MRP performed under USG guidance becomes very, very easy. So, ladies and gentlemen, wish you all PPH free practice. Thank you very much. And simple request, because I'm contesting for this vice chairperson in the September election, please support me and vote me. Thank you very much.
Thank you so much, Dr. Harish Doshi. Sir, it was a very, very nice presentation, crisp. And one thing I just wanted to say, that with the advent of carbitocin, we obstetricians feel really blessed now. Because I find that after years of practice, the amount of blood loss is remarkably reduced. And routinely I'm using carbitocin. But just one thought crossed my mind, that suppose we've given carbitocin, but the placenta does not separate out. It normally does very smoothly, and we are forced to do an MRP. Then would we like to give IV oxytocin drip?
Theoretically, it is said that carbetocin once used, all receptors are occupied. So oxytocin does not work. You have to give prostaglandins.
One thing,
right?
Dr.
So
Joshi.
oxytocin does. Yes,
Joshi.
madam. Just a minute. We are doing digitation, and couple of cases that happen because my students is doing digitation at cesarean and second student at vaginal delivery, and very good results. But in one case there was retained, but that was removed easily afterwards.
So prostaglandins would you would prefer?
Because theoretically oxytocin is all receptors are
theoretically
occupied.
it has already occupied the receptors.
Yeah, that's why. That's why.
And what about those ladies who deliver in the remote, low resource areas? What would you advise them? Like their deliveries are at home deliveries, then they are in villages where ASHA workers are working, and they do not have all these resources which you are having in the tertiary area.
Good question,
Yes.
madam. For that, WHO takes care of the whole world, no? So all third world countries and all that. So they have said misoprostol, as well as the IM oxytocin. ASHA workers can give IM. IV is not
No,
there.
I'm not. I would advise misoprostol.
Correct,
Orally,
correct,
sublingually,
correct, madam,
rectally,
correct.
whatever the...
Correct, madam.
So actually in some remote areas of Africa, the government has done one thing, that when the ASHA workers go to the lady at
Yes,
home in the
yes,
villages, so they give 600 milligram
Yes,
misoprostol,
microgram.
and they say that once the baby is out and the placenta is out, just put it under your tongue.
Correct.
That she can do herself,
Yeah, yeah.
otherwise she needs a nurse
WHO,
to give
after
IM.
lots of studies have come down to
they should be
oxytocin,
also-
but not for remote areas.
advised that if they have any problem, they should transfer the patient immediately.
Correct,
They should not waste time
Yes,
to the tertiary centers.
No 3 delays. Very
May I
good.
request chairperson to please conclude the session? We have
Dr.
next speaker
Joshi,
waiting.
now I will be complimenting you for your last line, that active management of third stage and have a PPH-free obstetrics.
Thank you, madam. Thank you, madam.
For the enlightening lecture. Now I would request the chairpersons to invite our next speaker for the session.
Yes. Now I invite Professor Arup Kumar Maji. He is MD, DNB, FICOG, and he is the president ISOPAB. Presently Professor Shantiniketan Medical College, Bolpur, West Bengal. Author, Bedside Clinic in Obstetrics and Bedside Clinic in Gynecology, Operative Obstetrics and Illustrated Manual.
Thank you, madam. Thank you.
These are so many.
Thank you. Today, when I was sharing the session in the morning, in the video session, one very famous lady who was with me was the devoted her life for the womanhood, and also particularly for the hemorrhage. That is what Dr. Silamila is asking. In our younger days, we have so many placenta previa, central placenta previa like that. So why now today is the worried actually? There are so many things to discuss about that. Thank you for the organizer and the chairperson, all the eminent persons or the audience here for giving me this opportunity to speak on the cesarean section in the placenta previa. It is really only for placenta previa is less discussed. Now we have concentrated our mind into the placenta accreta spectrum. Mina was requested me to this thing. And now issues. There are some issues. What are the issues? Cesarean section is almost rule in the placenta previa and challenging due to severe hemorrhage, that is the placental bed hemorrhage and the atonicity. And technical difficulty of the cesarean section is in the placenta previa, and so there is difficulty in the baby delivery if the placenta is anterior. Almost half of the cases of the region of the CS is excessive bleeding and is in the unsuitable time in emergency arises. Half, 50% cases. In anterior placenta PVA with prior serious morbidity, adherent placenta is common and hysterectomy is almost. This is the newer things, like the few decades, 5 to 10 decades of the much cases has come. That is all are very worried. And placenta PVA is a risk factor for postpartum hemorrhage, blood transfusion and hysterectomy. And also one thing is that the incidence of the placenta PVA is rising during the last 3 decades. 0.4% to 1 cases per 250 to 400 deliveries. And uterine bleeding in the mid-pregnancy is almost the diagnosis is the painless uterine bleeding, and it may be recurrent. And sonography is the diagnosis, is the mode of diagnosis nowadays. Initially it is done abdominally, then transvaginal. If there is a bleeding, there is no problem. And placenta previa is now classified according to the NIH classification by the ultrasound simple way. The placenta previa, the internal is covered partially or complete, and low-lying placenta, the placenta is within a 2 centimeter diameter. That is the present calculation. An MRI is useful in evaluation of the PAS, particularly, not for the placenta previa is routinely done. So this is the picture of the complete placenta previa, lower placenta previa, simplified from the classification nowadays. Now sonography is the most accurate event with vaginal bleeding. And placenta previa without prior CS, you will have to repeat it 32 weeks. And if it is still within 2 centimeter from the was at 32 weeks gestation, repeat at 36 weeks gestation. But if it is placenta PAS is diagnosed is 18 to 20 weeks gestation with prior CS. So you will have to do the repeat it. No such recommendation anywhere, but you will have to should do 28 weeks and another is the 32 weeks and accordingly thereafter. Now delivery time, when you will do the delivery in there? Timing of delivery depends on the patient status. Stable patients uncomplicated, there is no complication, you do plan it at 36 to 37 weeks. Because the risk associated without continuing the pregnancy are greater than the risk associated with the prematurity. In fact, 36, 37 weeks is no problem if the date is everything in, and even the maturity, lung maturity test is also not needed. Now emergency delivery. Any vaginal bleeding with a non-assuring fetal heart rate, which is not controlled, which is not corrected, and life-threatening hemorrhage, refractory, and also the patient is in labor. And optimization of the delivery of the woman with placenta previa, prevention and treatment of the anemia during ANC, discuss regarding the delivery, indication of the blood and blood transfusion, and the need for hysterectomy, all you will have to discuss. Delivery is done in a setup where blood transfusion and critical care facilities available. Usually it is done in the tertiary care center, should be done. And keep the appropriate surgical and inform the sister to make all the instruments ready for the hysterectomy. Senior obstetrician and senior anesthesiologist should be there. And evaluation of the placenta previa accreta should always be done, particularly if it is in the following the prior CS. And it is done in the antenatal period. PAS should be suspected in all cases where there is anterior placenta previa and previous cesarean section, and be ready for that all the consequences that may occur. Anesthesia, usually the general anesthesia if the patient is unstable, but regional anesthesia is also recommended and accepted if the patient is stable, fetal heart rate is normal. It is the choice of the anesthetist. At least before the dealing with the placenta previa, during cesarean section, at least 2 large IV cannulas should be placed, because as soon as the patient go into shock, we will not be able to do the IV line. The mode of delivery, practically all women with placenta previa undergo cesarean delivery except few cases. Vaginal delivery may be attempted when the placental age is the more than 10 millimeter from the internal loss, because the risk of hemorrhage during labor is much lower. And vaginal delivery is some rare circumstances in case of fetal demise and a pre-viable fetus, and the mother hemorrhagic will is stable. Techniques of the cesarean delivery. Longitudinal abdominal is beneficial, but some people do also the transverse incision. And unsuitable delivery needs the quick entry and quick closure, and also generous operating space inside the abdomen for the hysterectomy. And the types of the uterine incision, low transverse hysterectomy is the preferred method. Vertical uterine incision classically sometimes needed. This is the low transverse hysterectomy, and there is a vertical uterine incision. Low transverse hysterectomy, the chance of bleeding of the placenta is implanted anteriorly and the placenta is cut through. So fetal delivery is done quickly. vertical uterine incision is preferable in some instances, where sometimes in case of abnormal lie, particularly if the prematurity, narrow lower uterine segment, that is the uterine segment is not formed, an extremely vascular lateral aspect of the ellipsis, lower uterine segment. Abnormality of the uterus or uterus is distorted due to fibroid. The placental localization and uterine incision. Better to avoid disrupting the placenta when entering the uterus. Pre-operative or intraoperative sonography localization is helpful. Intraoperative sonography is a newer thing, but it can be done with a completely sterile technique. And placenta anterolateral location, a vertical incision is made in the lower uterine segment opposite to the placenta. And placenta if wraps around the cervix from the anterior to posterior lower uterine segment in the midline, a transverse or vertical incision may be possible above it. And standard lower transverse incision usually no problem possible in most of the cases as the lower uterine segment is well formed at the term pregnancy. The basic steps, some tips. The dilated veins of the anterior are ligated above and below, and then the incision is given between. Some I have seen by the senior surgeons to give it, and I also follow it. And as the presenting part is high up and the vascularity, bladder flip needs not be made in that cases. Access is done through the upper part of the lower uterine segment. Now delivery of the baby, there are the two options. Fingers are entered through the edge of the placenta above or below, whichever is near and passing through the membrane, either to bring the fetal pore near the incision or baby can be delivered easily by the breech extraction. This is the preferred method. And going through the placenta by the incising it, speedy delivery of the fetus is done and cord clamp immediately. A significant loss of fetal blood occurred, resulting fetal anorexia. This is not preferred. Following delivery of the baby, umbilical cord is clamped immediately. A bolus and infusion dose is started. The uterus is exercised, not essential, and a uterine repair is proceeded. Now, steps to minimize blood loss. Uterine incision bleedings are clamped with sponge holding forceps. Sponge holding or allystic forceps is not so effective, so sponge holding forceps from the incision. And each angle is ligated separately. With the sufficient oozing, it was exercised, pressure is given in the hot sponges inside and kept for significant time. It is at least 4 minutes. If there is still oiling up, the lower segment export and bleeding are ligated with figure of 8, 20 catgut, overswing suture, the Chow circular suture. There are so many sutures. If bleeding is generalized and not controlled, bladder flap developed and uterine artery ligation by many of the surgeons. I have seen in the morning by the experts also. The tenexamic acid and additional uterine administered. Massage and compression of the uterus is done. Compression suture that traverse and compress anterior and posterior like the cervical isthmus suture. Cervical isthmus suture is very important, and anesthetic attention should be drawn at this point whether there is a patient going into shock. The cervical isthmus suture, we used to do this with then on one artery forceps, the transverse, and another is the vertical compression sutures are placed in the lower uterine segment to compress anterior or posterior to reflect the bladder downward. This is the who compressive suture, that is the longitudinal suture, and multiple 8 compression sutures, the circular sutures are given. And the temporate with the Bagri or Foley balloon can be used. Combined use of Bagri balloon and Foley, the compression suture, and tightly packing the lower uterine segment and keeping it the 12 hours and remove it after 12 hours, has been also reported. And DD's compression suture is circular isthmic cervical compressive suture associated to be the Foley's catheter inserted in the cervical orifice. And there are some options in subendometrial injection of the vasopressin, stepwise uterine revascularization, pelvic artery embolization, and the gel foam occlusion of the anterior division by the interventional radiologist. A uterine atony, the upper uterine segment, if there may be bleeding, the Billy suture and other sutures also can be given. In rare cases, hysterectomy is needed. In past, the incidence of the hysterectomy with placenta varies 2 to 15%. And this is the Chow multiple suture that is more effective in case of particularly the upper uterine segment. The special problems of the placenta previa in the pregnancy with the prior cesarean section, cesarean hysterectomy without attempt of the placenta with the treatment of choice, and nowadays other than in the exceptional talsis. So this is the uterine incision in the past, the upper uterus you can say there, and the upper uterus above the level of the placenta previa. And now a small video of the past I am showing. Many of you have maybe seen it is. That is the small video. This is the past video. For the past, there are ultimately the obstetric hysterectomy was done. You can see we select the line of incision above the placenta. It may be even go to that fundus and so behind it. And the patient, it was the breast presentation as the placenta was below, the head is delivered and a clamp cut, umbilical artery cut, a clamped cut after ligation and incision. Then we do in these cases, all cases of the past in all institution used to do the internal ligation, and Dr. Sosi has beautifully shown the internal ligation. The full video was with me, but I am not able to show the internal ligation. It's not so difficult. This is not recommended by the ACOG, but it can be done. It is very effective in case of past we routinely do. So one after another, after the round ligament, then the upper clamp leg cut is done. That is the pedicle is done. Then most important plus is the bladder dissection with the fine diathermy, bladder dissection. And if the bladder is involved, don't be worried. You go, bladder may be involved and it may be open, no problem. Because bladder, if bladder, just 2 minutes.
We added 2 minutes. Okay.
Actually, there is no myometrium. That case, that has operated, that is the no myometrium there. You can see. That is the no myometrium.
uterine tissue नहीं कोनो uterine tissue नहीं है ना तो
So the take-home message is, practically all women with placenta previa undergo cesarean delivery with few exceptions. Emergency cesarean delivery becomes necessary in more than half of the cases due to the torrential hemorrhage. A low transverse hysterectomy is usually done slightly upper level, may be needed. Vertical uterine incision may be preferably in some instances. It is always better to avoid disrupting the placenta when entering the uterus. Placental hemorrhage is to be tackled rapidly with all available material. Particularly the junior will be trained on that, how the placental blade hemorrhage can be tackled. It is not so difficult. Anterior placenta previa in women with prior uterine incision, always think of morbidly adult placenta, need for hysterectomy. Maternal and neonatal morbidity and mortality ratio are high for women with a placenta previa. Cesarean section is in placenta previa is challenging one. Thank you for your patience sharing. Thank you.
Hello, Dr. Arup Maji sir, you have explained very well that all placenta previa cases need cesarean delivery. Only in ones where there is no previous antepartum hemorrhage with placenta is at least 2 centimeter away from the cervix and there is no scissor scar, can it deliver safely?
Now that is the guideline is there.
Yes.
If there may be low-lying placenta,
Yes, yes.
but it should be not within the 1 centimeter.
Yes,
That
yes.
is the
At least
that is
2
the
centimeter
guideline.
away.
So
Yes,
above that, it can
Yes,
be
yes.
allowed depending
Allowed.
upon the condition of the patient. And other vaginal delivery can be allowed, or the baby is
in
already
these cases,
dead, or the pre-viable
yes,
stage.
yes.
So these are the indication of the vaginal delivery. If the baby is living, we do
maternal
not usually
mortality
allow.
rate is
That's the
appreciable
guideline I have
amount,
seen.
so it can be in expert hands and trained hands with blood backup, and cesarean is the best. So we
Actually, placenta previa leads to PPH, lots of hemorrhage. So I would advise 3 PPH formulas, that is PPH care bundle, then PPH kit, which should be ready from beforehand, and lastly, PPH drill, where people from PHCs, community centers, all should be well trained to handle these emergency cases.
And
That is what I would like
in
to
my
say.
first slide I have shown is the
Yes.
more prone to PPH you'll have to deal with. Dr. Doshi already highlighted those things.
Yeah.
And first lecture, the how to
All right.
tackle the PPH and
With
prevent the
this,
PPH.
Dr. Manji, a very nice presentation, and I saw a repeat video today, the cesarean one. I have seen it before.
Yeah.
But it was an excellent presentation with all the complications, what should be done and what should not be done with placenta accreta spectrum. And thank you for your nice presentation.
Thank you, organizer, particularly Dr. Meena, Dr. Amrita, Dr. Pragya, all the organizer for inviting this. There is a very, very good and handsome conference, actually, hands-on conferences.
well, thank you. Let's have a round of applause for our chairperson and both the speakers for the first session of our scientific program.
Yes.
All of you, please come down.
Madam, please come. Please come here.
Very good afternoon. Welcoming you all to the keynote session sponsored by Bharat Serum Vaccines. It is a plenary session, and for this session I would like to invite Madam Dr. Promila Modi, Dr. Sushma Pandey Madam, Dr. Kumkum Sinha Ma'am, Dr. Supriya Jaiswal Ma'am.
All the chairpersons.
The Senior Consultant Ops and Gynae, Shubda Clinic and Ultrasound Center, and she is the President of Patna Menopausal Society 2024-26. Welcome you, ma'am. We have Supriya Jaiswal, ma'am. Ma'am is a Senior Consultant Ops and Gynae SM Hospital, Patna, and she is the Chairperson of Adolescent Health Committee, Pphcon 23-25. Welcome you all, ma'am. Now let us quickly move on to introducing the speaker for this session.
Thank you.
I would request chairpersons to kindly introduce the speaker for this session. Thank you.
Good afternoon, everyone. I think it is the post-lunch, so the dumping syndrome as we used to hear. But you will hear such a lecture now which will break your sleep. You will have to be awake and listen to. I invite Dr. Bhaskar Pal, please, to be on the dais. It's a formality to introduce the speaker. Otherwise, if I ask the audience how many of you do not know Dr. Pal, no hand. Everybody knows Dr. Bhaskar Pal. So, but still to perform the, I would like to speak few words. He is DGO MD from Mumbai, DNB, FICOG, FRCOG, Senior Consultant and Gynecologist at Apollo Multi-Speciality Hospital, Kolkata. He is the chairperson of Endoscopy Committee, CEFOG. It's a very good thing that we are having amongst us. Chairperson of AICC RCOG 2021 and 23. Immediate past president IAGE. Pphcon representative to CEFOG 2021 to 23. Chair Organizing Committee, AICOG 2023, Kolkata. Here I stop my voice because we all, most of us, have experienced the glory and the respect, and you see how much they have taken care, Bengal Obstetric and Gynecological Committee. And we have seen, Dr. Pal, your capacity, tremendous. It's praiseworthy, really. Past President of Bengal Obstetric and Gynecological Society, Vice President Pphcon in 2017, Clinical Examiner of MRCOG Part 3, and author of over 40 papers and book chapters. This is something which has something that everybody knows and would like to know. I have something to say from my own side. Dr. Bhaskar Pal is a dedicated, true Pphconian, I should say. very few people are true Foxians. He is one of them. He is a soft-spoken and friendly to most of us. His tremendous capacity and capability is praiseworthy, as I said, and which most of us have witnessed. Sir, may God bless you to achieve greater heights in future for everything and especially humanity. Thank you very much, sir. Now, over to Dr. Sushma Pandey.
Very good afternoon to all of you. And today with us, Dr. Bhaskar Pal, he is going to speak on the anticipation and the medical management of PPH. And as you know, the PPH is the most common cause of maternal mortality during pregnancy all over the world. And at least one woman die in 4 minutes. So it is very important topic, and now I will request Dr. Bhaskar Pal to, podium is yours. Please go on your talk, with your talk. As
Um, while I think they sort out the PowerPoint moving, two small things. I think this morning, Dr. Meena and Dr. Amita were worried about that we have so many registrations, where will people sit? So while I was waiting at this time, we figured out a way, and that's what Dr. Harish Doshi, Dr. Maji and myself were doing. That when you get down, find out who the next speaker is and go and sit there. And madam, when you finish chairpersons, you'll see your place is taken. See who are the next chairpersons, go and sit there.
yeah, that is more important to save the time.
Okay, I bring you greetings from Kolkata. Dr. Harish Doshi at lunchtime told me, don't mind, I'll have to cover a bit of carbetocin. I said, this is a PPH conference. Same things will be repeated several times, and that is good. We need to go in people's heads. So there would be something, we all know what is PPH, and we know what is PPH. We've not come here to learn what is PPH. We've come here to learn how to manage that. It accounts for 35% of all maternal deaths worldwide. The incidence is around 2 to 4% after vaginal delivery and about 6% after a cesarean section. We know that approximately between 2003 to 2009, 480,000 mothers died from PPH. And 99% of these deaths happened in low and lower middle income group countries. There is an increased need for hysterectomy surgery and hysterectomy in case of PPH, increased need for blood transfusion. If a mother dies, it's not only if lost her mother. 3 out of 4 healthy babies die within 6 months if the mother has died. Daughters have to adopt the role of mother and may miss out on education. The loss of income leads to a deepening cycle of poverty for the family. So it is just not a mother dying. Now 3% in all vaginal deliveries is the death rate of PPH in spite of appropriate management. The global incidence is around 11%. 40% die in level 1 facilities, which are clinics and district hospitals, and 50% of the deaths occur within 24 hours. The uterus can bleed at a very, very ferocious rate, and within 10 minutes, the patient can collapse and die. So how do we anticipate it? We anticipate it, we know the etiology and the risk factors in PPH, and they go by the tone, tissue, trauma, and thrombin. So antenatally and intrapartum, if there is an uterine overdistension, say multiple pregnancy or hydramnios, if the patient has been in prolonged labor or has been on oxytocin for quite some time, if there is suspected uterine infection or chorioamnionitis, if there is an uterine abnormality, or if the patient has received uterine relaxing drugs, then she is at a high risk of PPH. The most important risk factors is a previous history of PPH as well. During delivery, if you have a retained placenta or incomplete placenta at delivery, then, and of course, there is traumatic PPH and etc. But the uterine atony is the commonest cause of PPH in 50% cases. Yes, we've gone through a workshop showing you surgical ways to manage atonic PPH and traumatic PPH. But please remember, 90% of atonic PPH respond to medical management. It is only in 10% that you need to escalate to surgical maneuvers. So what can we do to prevent PPH? We can correct anemia antenatally, we can anticipate based on risk factors, and we can practice AMTSL, which I will skip a little bit because Dr. Doshi spoke in detail. And WHO recommends that you should use oxytocin 10 in international units by slow IV. slow IV and not more than 10 units intravenous, because the uh, adjuvant that is used is a myocardial depressant. So if you give more than 10 units as an IV shot, the patient might go into hypotension. So if there is an IV access, or if there is somebody who can give an IV, then your method of choice is 10 units intravenous of oxytocin. That is the WHO recommendation current moment. WHO also recommends that you can use carbetocin 100 microgram IM or IV for AMTSL. Now the importance of carbetocin is that if the patient can afford it, it's better, because there are studies which have shown in India, in one of the studies, that about 50% of oxytocin, the quality was not up to the mark. And the main reason is it requires a very strict cold chain, and that is not maintained in many places. I think Saroj Madam was asking that what shall we give when there is nobody to give an injection. Yes, the WHO does say that, and it can give that we can give 400 to 600 micrograms of misoprostol. Either we can give that orally. We don't have to go for any other route. The midwife or the nurse or the ANM can give it orally, and that is for lay health workers as per the WHO recommendation. We can also use argometrine or methyl argometrine, but these days we do not use that much for the risk of vomiting. So this is, if you see the pathway, are skilled personnel who can administer injectable uterotonics available? No. Then what do you go for? Then you go for misoprostol 400 to 600 microgram orally. If there are skilled health personnel available, is oxytocin available, and is it of sufficient quality? If the answer is yes, then you give 10 units oxytocin IV, preferably, or IM. If oxytocin is not available or its quality cannot be guaranteed, then you go for carbetocin or argometrine, or a fixed dose combination of argometrine and oxytocin, which is called the centometrine, which again is developed for the nurses to give in the Western world. Or you can give misoprostol 400 to 600 microgram orally. Now, medical management comprises of blood loss estimation, general measures, uterine massage, oxytocic, tranexamic acid, and the bundle approach. Dr. Doshi told me about being repetitive, and I think throughout this conference, you will find emotive and bundle approach coming back again and again. So how do we quantify blood draws? There are subjective methods like visual estimation, or there are objective methods like gravimetric method, calibrated plastic sheet, and use of artificial intelligence. Now the gravimetric method is an indirect measurement of blood loss. And what we do is basically we weigh all the mops and swabs and the sheets, and we take for granted that 1 gram of extra weight is equivalent to 1 ml of blood. The problem is when there is dilution because of amniotic fluid, etc., that leads to inaccuracy. We do have a calibrated collector bag method, which is one of the most accurate. We know that the emotive trial, they used one, and we know that we saw the Chhattisgarh bag today. So these are the ones that we use. These are one of the most useful and accurate methods of looking at it. These days, everything has got artificial intelligence, and we have a smartphone app called Triton, which looks at blood loss by taking photographs of used surgical gauze and canisters. And this colorimetric technique analyzes the photographic and geometric information from the relevant areas and calculates the hemoglobin mass that is present in gauze or canister, and then you enter the preoperative hemoglobin level, and it will give you an estimated blood loss. Visual estimation, notoriously inaccurate, especially when there is a clot, and as surgeons we are actually very in the habit of underestimating blood loss. This is a swab. So this is around 25, this is around 50 ml, this is around 75 ml, this is around 100 ml. That is how we estimate. But you look at this and this and this, you give to 3 different people, everybody will say different. Somebody would say 25, somebody will say 50, and somebody will say 75. When it's fully soaked, it's easy. 1 fist is equivalent to 50 grams of clots. And this is what we do a quantification of blood loss postpartum. Subjectively, a full kidney dish is 500 ml. When blood spills on the bed, it is 500 ml. When blood spills onto the floor, it is another 500 ml. When there is a floor spill with a diameter of around 10 centimeters, it's around 350 ml. And one is a swab which is fully saturated, it's around 350 ml. A sanitary towel which is fully soaked, which you use during delivery, is about 100 ml. The next bit is resuscitation. Call for help. You cannot manage postpartum hemorrhage alone. And we go back to our ABCD where we secure the airway, breathing and circulation. We put 2 large bore IV cannula. We start the patient on oxygen. We send some blood for cross-matching, CBC and coagulation. It will be very good that you take one test tube and put it there to see whether taking normal time or a longer time to coagulate. And depending on the blood loss, you consider transfusion. And at the same time, somebody is looking at what is the clinical history and what is the likely cause. If it's a relaxed flabby uterus, it's an atonic PPH. It's a contracted uterus with bleeding, then it's possibly a traumatic PPH you need to rule out. If there's an undelivered placenta, then it is a partial or total retained placenta. If you can't feel the fundus of the uterus, you're possibly dealing with an inversion. If it's a contracted uterus and the placenta is delivered and there is no trauma, then you consider that it's a coagulopathy. And then, you talk of shock index. I think this morning we heard of shock index from Chhattisgarh. The shock index originally was your heart rate upon your systolic pressure. And don't look at this. This is a modified shock index that WHO now talks about. That was simpler. And the shock index 0.7 to 0.9 is normal. So it's not easy to go and teach your nurses or ANMs what is a shock index. But the basic fact is, if your pulse rate is more than your systolic blood pressure, your shock index is more than 1. So tell your nurses, tell your ANMs that if the pulse rate is more than the systolic blood pressure, bring the roof down, call everybody down, because the patient is in moderate degree of shock. The WHO has now modified the shock index to make it heart rate divided by the mean arterial pressure. So it becomes the normal one, becomes 0.5 to 0.7. But for lay level, it remains the shock index. Uterine massage, very, very important. These are the uterotonics that we can use during PPH. Please remember, carbetocin is only for prevention, not for treatment of PPH. For treatment of PPH, you can use oxytocin, 10 to 40 units as a continuous infusion or 10 units as an intramuscular. You can use methyl argonovin, 0.2 milligrams every 2 to 4 hours. You can use 15 methyl prostaglandin F2 alpha or carboprast, which you can use every 15 minutes up to a maximum of 8 doses. If you can even give it intramyometrial, or you can give misoprostol, anything between 600 to 1000 microgram, and you can give it orally, sublingually or rectally. You cannot give it vaginally when the patient is having PPH. Oxytocin is your drug of choice, but as I told you earlier, please remember that IV bolus can cause hypotension. Ergots are useful, but causes nausea and vomiting and contraindicated in hypertension. Prostaglandins are generally pretty safe drug, but some people would get a bit of diarrhea and some people will get a bit of fever with prostaglandins, but essentially a very safe drug. The biggest advantage of misoprostol that it is cheap and it does not need a cold chain, very easy to maintain. You can keep it at room temperature. So please remember that misoprostol, if you give it sublingual, it's one of the best things is that it has rapid onset of action and a long duration of action. If you give it orally, it will have a rapid onset of action, but the duration is going to be short. If you give it rectally, the onset will be slower and the duration would be long. So sublingual is possibly one of the best way to give the misoprostol. So these are the Pphcon recommendations for management of PPH, that the uterotonics are the first line. You give IV oxytocin alone, and when IV oxytocin is not available or the bleeding does not respond, then you give argometrin or you give symptometrin or you give injectable prostaglandins or you give misoprostol. And so that is how you essentially escalate. Please remember again, carbetocin at the present moment is only for prevention. Now this is the emotive trial which looked at IV oxytocin infused as diluted in crystalloid solution administered over 10-minute period or injected slow IV, and then the patient would get 20 units IV oxytocin in 1000 ml saline with or without a misoprostol 800 microgram rectally or sublingually. Before I come back to the emotive trial, the other very, very important thing to use is tranexamic acid. And the results come from a woman trial. And woman trial looked at, they randomized 10,000 women to tranexamic acid and another 10,000 women to placebo, and they showed that 1 gram of tranexamic acid given by slow IV reduce the maternal mortality significantly. But you have to give the tranexamic acid as soon as possible. And if you give it after 3 hours, there's no survival benefit. So essentially, if you give immediately you give it, there's a 70% improvement in survival. For every 15 minutes of delay, there is a 10% decrease in survival benefit. If you give it after 3 hours of the onset of PPH, there is absolutely no benefit. So you can give 1 gram of tranexamic acid and you can repeat if the bleeding continues after 30 minutes or the bleeding restarts within 24 hours, you can give 1 more gram of tranexamic acid and this should be given as a slow IV. This is the Pphcon recommendation as well, same as the WHO recommendations. Recombinant factor 7A, data is very, very scant, but give it only if your back is to the wall and you think the patient is going to die anyway and she can afford it, then give it, it is expensive. And the risk is an arterial thromboembolism. That is why people in Europe are not very fond of it, but we have used it and the patients have made it. So we do not know whether the patients made it because it was in a destiny or it was because of this, but we need more data. So this emotive trial actually came from Africa. It is a multicentric trial and it showed that essentially by a WHO first response treatment bundle, which included uterine massage, oxytocin drugs, tranexamic acid, intravenous fluid, and a process for examination and escalation, improved the survival in PPH. So they looked at a composite outcome of severe PPH, requirement of laparotomy or maternal death, and there was a 60% lower risk of this primary outcome happening in the emotive trial. So basically, you will hear about the emotive trial more in detail in the LDI session today. So AM is massage of the uterus, O is oxytocin, T is tranexamic, IV is IV fluid, E is examination and escalation. So your take to work messages: correct anemia prior to delivery, anticipate PPH, practice AMTSL, diagnose PPH and shock early, resuscitation, looking for cause, treatment, arranging for blood will all occur concurrently, and that is why you require a team and that is why you need drills, so that people know that exactly what their role are and they know that they have to go and fit it like a jigsaw puzzle. Uterine massage is useful. Tranexamic acid should be used to treat PPH, sorry for the spelling mistake. 90% of atonic PPH respond to medical management, 10% will require Mahesh Gupta. We cannot have a talk on PPH without showing this. Yes, one of the wonders of the world, we love to visit it, but every time we see this, we should bow our head in shame that this is what it symbolizes is a woman dying of PPH. I take this opportunity, I've got 1 minute 20 seconds left to tell you about my journey in Phoxi. I have been in leadership positions. In 2005, I've served as the biostatistician to the journal, as chairperson of the Young Talent Promotion Committee, as a governing council member of ICOG, as a vice president in 2017, as a representative to SAFOG, which I finished this January. I have been a member of Phoxi Cell since its inception and have been the convener of the Violence Against Doctors Cell for 3 years. I would like to seek your blessings and support. I think somebody asked me that you don't come to Bihar so often these days. I said, just because the Bahu comes to your house, you do not forget your daughter. I have come here enough. Thank you.
Thank you very much, Dr. Bhaskar Pal, for a very nice presentation. And as you know, the medical management was very nicely explained by Dr. Bhaskar, but it is the anticipation is more common, as the patient is multigravida, multiple pregnancy, placenta previa, previous history of PPS, so one should always be alert for that. This time also she can get the PPH. Otherwise, we are using tranexamic acid first. As the PPH starts, shout for the help, and tranexamic acid is given. After that, all the medical management, uterine massage, we used to go, as you have explained very well. Thank you, Dr.
Yeah,
Bhaskar.
I think one key message people need to take is that, as Madam said, anticipation, prevention, early detection. Do not underestimate blood loss, estimate blood loss properly. We need to learn from her how to get these drapes, because we are negotiating with Pphcon now whether they can provide us the calibrative drapes that they used in emotive.
Thank you so much, sir.
not much time, 30 seconds. So as you mentioned about tranexamic and women 1 trial, so there is women 2 trial also, where tranexamic acid can be given slow IV prophylactically for the anemic patients. Okay, because we know in anemia that the clot dissolves early because of the less number of RMCs, the clot formation, even though it happens, it dissolves. So that is women 2 trial, and there is TRAP 1 and TRAP 2 trial also. TRAP 1 is again prophylactic tranexamic for vaginal delivery for all, and TRAP 2 is prophylactic tranexamic for cesarean. I think cesarean, most of the people must be using it already prophylactically. So these are the again further trials happening with tranexamic acid. So tranexamic acid plays a very big role.
Thank you,
I think.
madam. Thank you very much.
Yeah.
Dr. Pal. Hello, Dr. Bhaskar Pal. Yeah. I would like to have your impression. Whether do you think that Methergine is out of the shelf or still it should be utilized?
Methergine, I think the biggest use of Methergine at the present moment.
As a combination,
No, Methergine itself. There are two. Number one in placenta previa, because theoretically this is the oxytocin which works. Among the oxytocics, this is the one which works based on the lower segment. And secondly, Methergine when PPH occurs. So I think we should not be using Methergine as a first line, because too much of nausea, vomiting these days, most patients are awake. But we must have Methergine on labor ward because of these two conditions. One is placenta previa and one is treatment of PPH.
Thank you, sir. Thank you so much.
Can we go to the
now hand
next
over
speaker?
to Dr.
Yes.
Kumkum Sinha.
Please invite the next
I
speaker.
request the chairperson to kindly invite the next speaker.
Yes. The next speaker for this session, keynote session, is none other than the most popular immediate past president of Pphcon, Dr. H.D. Pai. His tenure as President Pphcon 22-24 was very remarkable, and he and his team worked tirelessly to achieve the Pphcon agenda and goals. He successfully launched the Anemia Mukt Bharat campaign and crisscrossed across many towns and states of India, including Patna.